areas or dependent areas. The perfusion in the dependent areas is improved, thereby improving the shunts. So it has a lot of benefits, and the patients with a severe ARDS who are requiring proning, probably those are the ones, and that is a time when your patient's relative should be counseled for ECMO also, because these patients are likely to be benefited at this point of time with an ECMO as a modality. And they need to be identified. Are there any ways by which they can be identified? So how long you want to wait for proning? Well, we give 2 or 3 cycles of proning. We see the improvement in their lung mechanics. Welcome Dr. Rakesh and Dr. Prabhat. Please come. So we see the response of proning by seeing the changes in the plateau pressures, by seeing the changes in the driving pressures, by also seeing the changes in the mechanical power, and the stability of hemodynamics, the stability of a patient's overall acid-base disturbances. So that is how, these are the things which we monitor. So safer ventilation is something wherein we are limiting the plateau pressures, we are optimizing the PEEP, and we are monitoring even the driving pressures and trying to keep them below 16. Beyond that, so this was the evolving concept in lung protection. Dr. Luciano had very nicely, it has started around 25 years back. I remember seeing Professor Gattinoni in our Calcutta conference. And that was a time when we were sitting outside on the stairs, just casually, and he was talking about proning. And that was the first lecture when we heard him on the ventilator, I mean CT scans in patients with ARDS, and also proning in these patients. So we started speaking about driving pressures, we started low ventilating power, low driving pressures, and thereby reducing cumulative injurious strain. And over a period, the concept has emerged with a mechanical power, whether it carries any meaning, whether it has any use at the bedside, and what are the limitations of mechanical power or calculation of mechanical power. So mechanical power is a summary variable derived from solid physical and biological foundations that can be included in any ventilator to monitor the safety of mechanical ventilation and guide lung protective strategies. It is to ventilation that what SpO2 is to the body. Like SpO2 gives us a lot of information about oxygenation, oxygen consumption, cardiac output, and hemoglobin. Similarly, mechanical power, it can, that is optimum, so probably your tidal volume is proper, your PEEP is proper, your driving pressures are proper, your compliance is improving, your residual capacity has improved. So all these things can be implied from the mechanical power. In the same way, it indicates that one or more variables are excessive, and you know what is to be titrated to get an optimal power. And that is where probably the optimum ventilation would come. These are physiological foundations when we want to titrate these various parameters like PEEP, tidal volume, pressures, and the respiratory rate. And we want to optimize it to such an extent that we get a mechanical power of in an acceptable range. This is a formula. This is an easy formula, but when we are reading article on mechanical power, it sounds very complex. But probably there is one simplified formula or a surrogate formula which can be used for patients who are on pressure control ventilation or the patients who are on volume control ventilation. So these are two separate formulas. We tried to do something at the bedside in our last patients whom we put on ECMO or whom we did not put on ECMO, because this question of when to put the patient on ECMO and which patients are probably pressures, PEEP, and inspiratory flow. These all parameters are displayed on ventilator, and subsequently, moment the patient has severe ARDS, we calculate their PaO to FiO2 ratio. If that is going down, we put the patient on controlled ventilation, volume control or pressure control. We calculate the mechanical power when they are in the supine position. We counsel the patient at this point of time if the mechanical power is high, and mechanical power can only be seen if the patient is adequately paralyzed and completely controlled. There should not be any efforts from the patient. So we counsel the patient for ECMO, we prone that patient and see any improvement. Calculate mechanical power after 6 hours, watch for any change in mechanical power and hemodynamics. If the patient's lung mechanics are showing any improvement, and if the hemodynamics are also better, then probably that patient is recovering. We continue proning, we recheck mechanical power, note change after 12 hours. So second calculation of a mechanical power will be done by the doctor in the next shift. Then comes the supine cycle. Moment the patient is made supine, we watch hemodynamics, we calculate mechanical power again, watch for change in mechanical power. Now, once we make a patient supine and the mechanical power is increasing, it is earlier has become better in prone position and it has increased again. So probably that patient is a patient which is fit for ECMO, and this patient should be put on ECMO. Now, this is a recent trial that we had done. Trial means of a single patient attempt that we had done. This patient was an H1N1 patient who had a severe ARDS. We proned him twice, and we seen that improvement in mechanical power. That patient was on control mode. However, and then when he was made supine, again that mechanical power did not worsen, and we did not do ECMO in that patient, and that patient recovered. Maybe the same algorithm can be made and can be followed for a patient to decide whether they will need ECMO or not. This has not come anywhere, but this is what I just thought whether this can be done. Speaking further about mechanical power, there might be a time will come in another year or two wherein it would actually be incorporated in a ventilator as we calculate auto PEEP, as we calculate dynamic and static compliances, driving pressures, etc. Similarly, mechanical power will be incorporated in a ventilator, and probably the life will be made easy for intensivists to take a decision whether this patient will go for a ECMO or not. Having said that, I am stopping here. Now the ball is passed on to a ECMO team to speak up everything about ECMO. Thank you so much.
I would like to welcome Dr. Munish Chauhan as our second speaker. He will talk about the different types and indications on ECMO. Thank you.
Very good morning to you all, and thank you, for this opportunity here, Dr. Barokar and our team, to come forth here and discuss some of the nuances of ECMO. Main aim that today's lecture and today's workshop will be to introduce you to the concept, so that am I loud? Is it okay? So to introduce you to the concept of ECMO, so that you start reading further, start attending advanced trainings further. It is not, ECMO is not a modality that you'll be able to, master in one session or one day, but it is an eye-opener. It is something which touch bases with your, raises your interest in the specific field. So next 20 odd minutes we'll be discussing about some of the indications of ECMO. My stress would be more so that you understand when not to put ECMO, especially in our setting. It's always better not to get into a state where you are not able to get out and you don't have an exit strategy. So we'll be discussing some of the indications, some of the cases where we would go for a VV or a VA ECMO, and would just touch us in the end on hybrid modes. Can you slide change? चेंज हो जाएगा, चेंज हो जाएगा. If possible, you can start. We can change the slide there. So some of the slides are courtesy of the person who trained us in ECMO way back in 2014, Dr. Mullah. He was an active participant in our conference in Delhi also. So there were several events that led to the development of ECMO as we see it today. Most of it came out of, as we said, the cardiac surgery OTs from the cardiopulmonary bypass machine, the CPB machines. It all started with the development of oxygenators, and with over time these oxygenators became more compact, more biocompatible. The surface area in a smaller size of a casing was packing more and more area so that a good amount of gas exchange can occur. So as we are discussing, as Dr. Barkar was saying, Gatton being one of the pioneers of ECMO, ARDS, the pioneers of ECMO was Bob Bartlett, and these were the historic cases. One of the first adults, a motorcycle accident, young victim, 1971, and the famous Esperanza. It's not working. Slide is not. Okay. Can you change the slide from there only? One of the first neonatal survivor of ECMO was Esperanza, who you can see in this pic here with Bob Bartlett, the person who saved her life. So this was one of the initial events where ECMO started coming into the medical purview. It didn't take off well. There was initial studies which said that ECMO is not a modality which is that helpful, that successful. There were several studies which said we do not recommend extracorporeal support as a therapy for ARDS. This was way back in 1994. So though it took off well, there was an interesting concept, but it took a lot of time to be accepted as a modality, and I would say we are still not there. It's still not accepted as a modality as such at this point of time. It is only the pandemic situations that create interest in ECMO or any other modality which seems to be life-saving. So that's why in 2009, when the H1N1 pandemic set in and it was overlapped with the Caesar trial, that it took off. So that was the phase when ECMO came into, especially in adult patients, and adult ECMO came into interest, came into being, and 2008 and 2009 region was where there was spike in ECMO. Then came the earlier trial, the famous earlier trial, which created doubts in our mind. Okay, we have a special separate class on lecture on trials, so I'm discussing there. And then came the COVID pandemic. So we are right now in the aftermath of the pandemic. There's a lot of interest in ECMO. A lot of centers now started doing ECMO. So, and let's see how we go out from here. So what are the indications? When do we start thinking of ECMO? Dr. Rajan very nicely has already created a mindset here that this was one of the patients that he discussed, which is not being handled by conventional modes and requires ECMO, especially the veno-venous ECMO. So we basically have two types. Okay, if you divide, we have two types of ECMO. We have a cardiac support ECMO and we have ECMO for pulmonary support. Any condition where the heart is unable to pump out sufficient blood to meet the metabolic needs of the body, as simple as that. Okay? Conventional means are not able to support it, we have to think of ECMO. Similarly, if there is inadequate supply of oxygen to the body cells and inadequate removal of carbon dioxide, after conventional maximal therapies, in the last lecture we did everything, you have to think of ECMO. So this will be a veno-arterial ECMO, this will be a veno-venous ECMO. Yes, it looks combinations, permutations, but I'm not going there right now. Okay? So we have a critical ill patient and any other form of treatment which is not working, okay, we have to think ECMO, especially when death is imminent. So it is sort of a last line. Okay? This is when conventional measures have failed, but the disease is not irreversible. Once it's irreversible, then there is no point in going for ECMO. So veno-arterials, in simple terms, blood is taken out from the venous system. So this is a terminology, veno-arterial system. If you go to the site of ELSO, the Extracorporeal Life Support Organization, elso.org, it will have all the papers and the guidelines. And one of the guidelines states the terminology. So when we talk of VA, veno-arterial, V-A, the veno is from where it is being drained, arterial or the A part is where it is being returned. Okay? So blood is drawn from the venous system, oxygenated, purified, carbon dioxide removed, and returned to the arterial circulation. So this is a circuit, which is, if you remember physics, it is a circuit in parallel to the systemic circulation. It is a circuit in parallel to a original systemic circulations. So it provides almost complete, I won't say complete, I would prefer the partial word, partial support of the heart and some amount of oxygenation to the areas being provided by the machine. Okay? So this is the cycle that it goes. So if you can see in the diagram, the blue part, this is the venous drainage. From the RA, the blood is being drained, being taken to the pump, pushes to the oxygenator, oxygenated, it becomes red and is returned in the femoral artery. Depending on the flow, it will go up till almost the thoracic or the ascending aorta, descending aorta. Then is the veno-venous one, which pertains to the case we had just discussed, patients of ARDS who require lung support. Again, go to the terminology, veno-venous. So we are draining from the vein and we are returning to the vein. After it goes into the vein, it goes into the systemic circulation. So it is a circuit in series. It's not a parallel circuit. The lung and the heart, the native lung and the native heart are still getting all the blood that goes from the machine. Okay? It provides some amount of partial support to the lungs as long as the cardiac output is sufficient. So it has almost no contribution to the cardiac output, almost no circulatory support. Okay? The idea is to give diseased lung time to heal or the diseased heart time to heal with less of aggressive mechanical ventilation or, in case of veno-arterial ECMO, lesser of high-dose catecholamines, which can have a detrimental effect in itself. So this is the cycle that goes. One is the intracorporeal, this is the extracorporeal. This is out of the body, this is inside the body. And this is in series to your intracorporeal blood cycle. Okay. So you can able to see we have a drainage cannula from the femoral side, goes to the pump and is pushed to the oxygenator, oxygenated, goes back to the same venous system. Okay. Later on you'll see that we have to keep a gap of at least 10, 20 odd centimeter into the tips. But we can have a second drainage or a return intrajugular, depends on the veins that you have. So it is a femoral combination that is draining from the femoral and returning to the femoral, or a femja combination, draining from the femoral, okay, and returning to the jugular. Okay. So what are the indications? Okay. Whenever we talk about indications, always just try and understand that it is not a treatment modality. It is just a supportive modality. Okay? Just like when we explain a ventilator to a patient's relatives, we tell them that it is just a support. It's keeping the patient alive, oxygenating the cells, providing support, metabolic support, and removing carbon dioxide till the body heals. So if we are talking about a disease that is not going to heal, then this is not the modality for the person. It's not something that you should suggest. Okay? So in cardiac indications, mostly there are a lot of mostly if in talks of short-term support, it's the patients who have had MI post PCI who have stunned myocardium, the ejection fraction is not effective, cardiac output is not there, able to meet the metabolic needs, lactates are high, and anaerobic oxygenation, this circulation is going on. So that is the time that we give in such conditions. Otherwise, end-stage heart failure is as a pre-transplant setting where we send them to Dr. Parvat then. Okay. So this is one of the indications post-CABG for weaning and valve replacements. A lot of indications are cardiac surgical indications, but if we talk about non-cardiac surgical that we usually put is in cardiotoxins like aluminum phosphide and post-MI, post-PCI patients. Respiratory ARDS. Now ARDS can encompass a big spectrum. It can be infective, non-infective, secondary, primary ARDS. As a bridge to lung transplant, which we saw several cases during COVID times, okay, or primary graft failure, pneumonia, sepsis with respiratory involvement. It's something which is a bit controversial at this point of time. And reversible respiratory failures. The word is reversible. Okay, we have to understand. So there has to be an exit strategy. Okay. It can be healing or it can be a transplant. So these are the questions that you need to ask yourself before you discuss with the family, yourself, your team, the primary physician. Is the disease pulmonary or is it cardiac? That's where you decide the modality. Okay. Is it reversible? That's where you decide your exit strategy. It's reversible, so I'm going to give, let's say 5-7 days for a cardiac one, maybe 14-21 days for a respiratory one. They take a longer time than a cardiac one. And then let's see. If it's not reversible, unlikely to be reversible, whether they are willing for a transplant. Okay. Any other disease which can make the prognosis grave. Let's say patient has a metastatic cancer, end-stage malignancy. There's no point. If the 6 months survival is not enough, there's no point in going to such length of intervention and modality, which is costly and dangerous to a little extent also. Okay. Whether ECMO will help or hurt. Patient has an intracranial bleed, has a history of bleed. Okay, has deranged INI. He has active bleeding. So will my modality worsen the status? Okay. Is this for a preoperative support or VA or VO? These are things that you need to be clear about when we go for a surgery, for this procedure. Okay. It's not working. So, in case of lung, a disease which is acute, which is life-threatening, which is reversible, and is unresponsive to conventional therapies, is the ideal patient for you. Okay, this is what the green zone. Okay. So, this is one of the few indications. Now, there several texts, several guidelines will vary between how you select the point which is a tipping point when you think of going for a modality or like ECMO. So. So which is, as I already said, reversible. Okay, PF ratios at 100 in the severe category of ARDS, with a gradient which is more than 600. Great amount of shunt fraction is some of the indications where you feel that now this is the tipping point. Contraindications, exclusion criteria, most of them are relative. Okay, except a few. We'll come to the later slides. Okay, then comes the timing of initiation. Guidelines say more than 7 days of high mechanical power ventilation, you should not go for ECMO. Okay. The earlier you put, before MODS sets in, before the second or the third organ sets in, and the lung is not damaged severely because of high power of ventilation, is the time. Okay. So, VA versus VV. Okay. We talked about how the indication differs. Okay. Now, as a modality, what are the pros and cons of each of the modalities? We'll see is that veno-venous will be supporting the lungs only. Okay. So we are not expecting any help on the cardiac part. That's where the hybrid modes will come. If you expect that the heart and the lung both need to be supported. Okay. Any emboli that happens here will be filtered mostly into the lungs. Okay. Whereas in the case of VA arterial ECMO, we'll have to be more careful because any embolus that occurs goes straightly to the arterial circulations. Okay. Okay, this we'll skip. Okay. So, brief difference between the VA and the VV is respiratory support, respiratory partial, some amount of, but a good amount of hemodynamic support. Vein to the vein to the artery. Generally, it is easier and safer to fiddle with the vein, a bit difficult to fiddle with the artery. That's why we mostly look for a vascular backup whenever we are going to puncture or play around with the artery. It's a bridge of recovery for heart transplant, whereas it can be a bridge to recovery to a lung transplant. Hemodynamic instability is not much here, okay, which is present there. The rest, I think we'll skip these parts, okay. So, just as I said, just an introduction to your selection processes. There are several guidelines, I say, but you need to read. Not enough time to go into the nuances of everything. But how do you select? Okay, this was a 2019 article which gives you a general flow of patient management and how to select the right patient at the right time for ECMO. Where ECMO fits in the algorithm of ARDS is the question that should come to your mind when you start going for ECMO program, especially a veno-venous ECMO program. So we have treated the underlying cause, okay. As we discussed in the previous lectures, lung protective strategy has gone on, diuresis or resuscitation is there. So you have optimized the fluid balance, you have optimized the ventilative balance. Still, if your PF ratios are less than 150, we go for prone position, as we discussed. Neuromuscular blockages, high PREP strategy, nitric oxide and recruitment maneuvers, though bit not favored now. Still, if PF ratios for more than 6 hours, I don't know if you are able to see it, but I can send you to you separately. If they are less than 80 for 6 hours or less than 50 for 3 hours, pH is less than 7.25. If there are no contraindication to ECMOs, we go for ECMO. Okay? So this is the flow. Your PF less than 150, you do all the maneuvers, keeps on decreasing, goes to less than 80 for 6 hours or less than 50 for 3 hours. If there are no ECMO contraindications, we go for ECMO. If oxygenation is adequate, still, but your CO2 is high, there's some amount of oxygenation failure, you can still go for ECMO. Okay. Similarly, is a flow chart for cardiology. I'm not going to show all these things, but you just need to know where are the situations we can go for ECMO. This is the American Cardiology College of Cardiology publication 2016, freely available on the net. You can see this flow here. So cardiogenic shock, cardiac arrest, high risk, PCI. These are the 3 big areas where we think of veno-arterial ECMO. Okay. High-risk PCIs, you can prophylactically put in cannulas and keep the machine on standby. Okay. Right now, these days, Impella is also being used for this. Cardiac arrest, this is the ECPS situation. If there's no ROSC in 10 minutes, you start thinking of activating the ECMO machine. At least within 30 to 40 minutes, you should be on flow. The third indication is cardiogenic shock. Okay. These are the 3 broad indications. I won't be going to details, you can just read this, you can get this online. Okay. If you talk about other mechanical support devices, here where is VA ECMO fits in. IBP doesn't provide much of a cardiac output support. There's Impella 2.5 to 5, depending upon how much support. That is more in the purview of the cardiac surgeons rather than the intensivists. And this is VA ECMO, which can provide support from 2 liters into very rare cases to 5 plus liters. Okay. So these are the effects and implications of extracorporeal life support on oxygenation, on carbon dioxide removal, that is ECOR, and on cardiac support. Okay. So I think, yeah. So these will be discussed in a different lecture, so I'll be skipping these parts. Yeah. So coming towards the end, other thing that I was tasked to touch upon was hybrid ECMOs. Now hybrid ECMOs are a mix of combinations, permutations of veno-arterial and veno-venous ECMO itself. Okay. As I said, the terminology is always the ones before dash is the drainage, one after dash is your return. Okay. So we can have several combinations depending if your veno-venous ECMO or veno-arterial ECMO is not able to get you there, not able to hit the seat slot. So let's say we have where drainage is not adequate. One cannula is not able to drain enough blood. So you can put in another cannula. So 2 cannulas are giving blood to the ECMO machine and it is being returned to the artery with a single cannula. So this is VV-A. Okay? Veno-venous dash arterial ECMO. So 2 veins are being drained. Mostly it's a jugular and a femoral, and it is being returned to the femoral artery. Okay? Veins can be both femoral. Okay? The idea is to increase the preload, increase the blood flow so that you can go for higher flows as much as your machine and the filter allows. Then there's another one is V-AV. So V-AV would be, I think you should now be able to understand hopefully. So V, before dash, it is the drainage, AV is the return. So one vein is being drained and it is being returned to one artery, A, which is a femoral artery, and another vein, which can be the jugular vein. Okay. So this is providing a combined support, some to the heart and some to the lung itself. Then again, depending on different sites of V-AV can be there, then they can be VV-AV. So I hope you got the gist. Okay. So many advanced centers do go for this support in complicated patients, in septic shock patients, patients of Harlequin syndrome, patient with ARDS and myocarditis. So if you have a complex case, you have to go to these complexities. But mind you, the more complex the combination goes, the more difficult it becomes for the patient to make through. I would end this with the words that we cure, but we don't support the healing. We are just supporting the healing here. We are not curing the patient. Okay. Last two slides, as I said when we started off, is understand the contraindications. Okay. Whenever you start off an ECMO program, understand when not to put it. Okay. It's like, you know, Abhimanyu's thing. Chakru mein ghustoge agar bahar nahi nikal payenge, then this is where, especially in our country, where finances are from the pocket, then you'll have to face the patient's eye that why did you give me a modality which now you are saying is not helping. So it has to be very clear in the start only that this is the case that I don't want my, especially when you start off a program. You are a well-running experience center, you have 100 cases under your belt, then maybe you can touch cases which are in the gray zone. But when you start off, you should be cases which do not have this contraindication. As I said, there are very few absolute contraindications, but when a lot of them are relative contraindications which have a poor outcome. Mechanical ventilation at high settings for more than 7 days. Okay. Major immunosuppression, neutropenic patients. CNS hemorrhage which is recent or expanding, that is an absolute contraindication. Non-recurring comorbidity such as major CNS damage, post-CPR, hypoxic patients or terminal malignancy. Age as such, is not a criteria anymore. If you can still put in ECMO as these things. Your indications need to be correct. Okay. You need to be clear when you start the program that in some cases I am not going to be doing it. In some cases I am going to be very selective. So at 75 I definitely might not do it. At 70 I might consider if all the other organs are intact, there is no comorbidity. It's terminal respiratory failure, the patient says no, the family says no lung transplant, I won't go do it. Okay. But if they are saying that we might go for we are ready for a lung transplant, then you might consider it. Okay. So you have to be clear that where I'm going to put my hand in different stages of my career as an ECMO specialist. Same goes for veno arterial ECMO. Okay. So, to summarize, VV ECMO for severe ARDS, ECOR is still upcoming, not clear whether in moderate ARDS we can use it as an adjunctive therapy to mechanical ventilation. Okay. Long-term support is something which can, especially we have seen in COVID, we have had months and months of ECMO runs. Some patients have come off without even lung transplant, waiting lung transplant, but has improved. So this is something which we as a nation need to see, because then the cost comes into play. Okay, and we know arterial ECMO is something which is very weak in our settings. In our setting also, even though we have done ECMO for the past 8-9 years now, but we know arterial ECMOs are still very less in our network. Okay. And so last slide. So a septic shock, ECPR. This is another question which is open for us. Thank you. So I hope I was just able to touch, this is a big topic to fit in 20 minutes, but just to give you an idea that this is where you have to ask questions as throughout this day and later on when you pursue this line. Thank you.
Hello.
Thank you so much, sir. Now, please join us in welcoming Dr. Rakesh V as our next speaker on the subject of patient selection, cannulas, initiation procedures, and expected difficulties. I request delegates to jot down any questions they may have, and that will be addressed and resolved at the workstations. Thank you.
Okay. Good morning, everyone. So thank you so much for the organizing committee for calling me here for delivering this lecture. And it's so privileged to stand in front of Manimala madam and deliver, because ma'am is my teacher and one more teacher, Dr. Sambit Sahu, is missing here. I really miss her here. So ma'am experience is more than my age. Privileged to be here, madam. Yeah. This is not working. Yeah, chalo. So next few minutes we are going to talk about selection of patient, cannula. Now how to initiate an ECMO and anticipated difficulties which we face. It's moving very slow. There's a discrepancy. Yeah. So coming to overview, I'm going to cover in terms of your introduction, selection of modes, patient, cannulation sites and technique. What are the various cannulas available? What is a decision-making factor in selecting the cannulas, and complications during cannulation, and how to face them once you are done and all. So, there is an electrochemical dissociation here. I'm unable to see the slides here, and slides here are completely. इसमें से? अच्छा. So complications during cannulation, how do you going to face that? And you need to select the appropriate patient in a crucial timing. That is much more important here for a successful outcome. Need to follow a scientific and evidence-based practice. Sadly, many patients are referred too late in India. When it comes to India, they'll do all kinds of proning, they'll do ventilation, ARDS net protocol, being known that the lung is not going to recover, and they refer the patient to ECMO after 2 weeks or 3 weeks of their ventilator trials. I mean, the more the duration on ventilator, the more the duration on ECMO, and the lesser the recovery rates. So ECMO is not a miracle machine. It is unable to recover and is unable to make the irreversible damage. It cannot make it into a reversible thing. So main thing is timing of starting ECMO is the key. It should be done before multiple organ damage has been settled in. Diseases need to be reversible. As my previous speaker is quoting, it should be a reversible disease. Team need to have a treatment plan and exit strategies. If you don't have an exit strategy, don't go inside. Only when you have an exit strategy, or you can think that patient can be counseled, then only go for the ECMO. Team should rely on the expertise and experience also, both. Choice of ECMO modes. So by this time, I think everyone must have understood, you have only two ECMOs, basically VV and VA ECMO. VV goes for the lung support, VA goes for both lung and cardiac support. If you can see this slide here, so this patient have a hemodynamic compromise. If the patient is hemodynamically compromised, and then if it is an RVA failure, we'll go for either isolated right heart support. We call it as PA and LA ECMO, or you can call it as a tandem heart. I'm going to show you the cannula in the end. You can go for VA ECMO also. If the patient has bi-heart failures, both RV and left LV failure, you can go for an VA ECMO. If the hemodynamic compromise is not there, if the patient is isolatedly having an ARDS, or it's a hypercarbia alone, you can try ECOR. If it is hypoxic, type 1 and type 2 respiratory failure, you can go for VV ECMO. Even for hypercarbia, you can try VV ECMO. It's not a contraindication though. Coming to the inclusion criteria, as I said, reversibility, PF ratio should be less than 75. Age is again a number. It's not going to be an absolute criteria. Murray score of more than 3. And non-compensated hypercapnia, which is pH of less than 7.2. A lung compliance of less than 0.5. So this is the Murray score which I'm talking of, which consists of 4 parameters. One is PF ratios, your chest X-ray involvement, the PEEP which you are going to ventilate the patient, and the compliance of the patient. So each score has got a score from 0 to 4 multiplied by, summing up of all the scores divided by 4. If the score is more than 3, that's an indication for a VV ECMO. So coming to VA ECMO, so intractable arrhythmias, it might be any kind of poisonings. An acute MI with a low cardiac output states, viral myocarditis with pulmonary embolism, a definitive criteria for VA ECMO. Cardiogenic shock due to drug overdose, wherein you have intractable arrhythmias also. Next thing is bridge to transplant. So Intermax, there is one classification called Intermax classification, where you classify heart failure patients from 0 to 7. So 0 is dead, 1 and 2 are moribund patients, and 7 is a near normal patient. So LVADs or ECMO stands in Intermax 1 or 2. So unable to wean from cardiopulmonary bypass in the immediate postoperative phase. Primary graft dysfunction, which happens after heart transplantation. So these are the various indications. ECPR. So one of the biggest indication for ECMO is your ECPR, VA ECMO. And how to select a VA ECMO patient? It depends upon the inotropic score. As I said, the refractory arrhythmia is unable to maintain the urine output. Cardiogenic shock with high inotropes. Lactate clearance. If your lactate clearance is less than 6 millimoles per liter, that is an indication with a very low, that's a shock, simple thing. Low mixed venous oxygen saturation and organ dysfunctions. So these are the every indications every one of us know. But I'm going to touch some other considerations where obesity is one thing. Generally, people will say the more you obese, the more the lesser the outcomes on ECMO here. So it is previously thought to be a negative outcome survival, but it has been disproven. But it's a challenge for the ECMO team to manage an obese patient, but it's not the outcomes on. Brain injury. So it depends upon the what type of brain injury it is. If it is a minimal IC bleed, yes, you can go ahead with ECMO. No need of discontinuing the ECMO with the minimal IC bleeds. You can go on heparin-free ECMOs. Sepsis. So again a concept of debate here whether to go for ECMO or not in sepsis, because ECMO itself is going to throw us a lot of sepsis complications. Failure of conventional management. So we should not wait much on here. So once your conventional management, if the PF ratios are going to 100, less than 100 with 2 or 3 sessions of proning unable to improve, go for an early ECMO, the outcomes will be very good. Coming to exclusion criteria, I can say these are all relative exclusion criteria. These are not absolute exclusion or absolute contraindications here. Irreversible disease like malignancy. We don't know if the malignancy is confined to one organ, you can again go for ECMO. There are instances where malignant patients went on for ECMO, they recovered, went home. Age more than 75, it's again a relative number. Intracranial bleeding, that should be confined. It should not be affecting a GCS, DIC and coagulopathy, a gross multi-organ failure, unwitnessed cardiac arrest. The ECPR guidelines says of low flow time of less than 5 minutes, a no flow time of less than 5 minutes, low flow time of less than 60 minutes, and a moribund patient. So all these are relative contraindications. They are not going to be absolute contraindications for you at all now. So the patient has been selected. So diagnosis of the disease has been made. So you come to know that which type of ECMO you need to keep. So next step is selecting the cannula. So how are you going to select the cannula? So what are the factors we are going to consider? So how many of you have done ECMO here? So many of you seen ECMO at least. So let us interact. What are the factors you consider? Anyone has seen the size of the vessel before going on to the ECMO, or is just the weight criteria? Only the weight criteria? No, before going on to the weight, you need to see the size of the vessel, and you need to understand the flow requirement of the patient. How much flow the patient requires. It depends upon the disease state. Type of ECMO, anyhow, we know that. So vessel size. So I generally do an ultrasound scan of the femoral and jugular vessels before going on to the ECMO. So wherein I can get the diameter of my femoral vessel, diameter of my jugular vessel. So why I'm supposed to do that? To select the appropriate cannula size. So to select that, what I should know. So can anyone tell me what is the conversion factor for mm to French or mm to gauze? 3. So 1 mm is equal to 3 French. So technically, if the vessel size is 9 mm, say for example the diameter of the femoral vessel, so what size you want to select? So 9 into 3, 27 French. So but I'm not going to fit the 27 French directly into the vessel. I will select one size smaller than the 27, because I don't want to occlude complete of my vein wherein your venous drainage is hampered and the patient lands up again in rhabdomyolysis or hyperperfusion syndrome. So select a size, one size lesser than the exact vessel size. That's the idea here. So selection of venous cannula, it should give full flows. So venous cannula has got 2 ends. Whenever there is a pressure drop, because the venous side there is a less pressure, with a pressure drop of 20 millimeters of mercury, it should give good flows. So that's the idea of selecting a venous cannulas. It should be weight based, disease based, and ECMO based. So this is a table which shows the weight based criteria. So based upon the size of the weight of the patient, you need to select the cannula size, so which gives a particular flow. Every cannula has got a maximum flow, which is depicted here in this chart. So disease based. So there are some diseases which demands maximum flow. Say for example a dengue shock syndrome, the cardiac output may reach up to 14 liters for an average 70 kg adults. So if it's a disease based, I prefer a bigger size cannulas with a multi-staged cannula. Septic shock, again the cardiac output demand is high, wherein you have to select a bigger size cannulas. Peripheral vascular disease, wherein I cannot fit exactly the size of the vessel, you have to select the smaller size cannulas here. So disease based. And severity of ARDS. If the patient is in early ARDS, the flow requirements are less. If the patient is in severe ARDS, complete lung cutoff, the flow requirement somewhere shoots up to 5 to 6 liters. So coming to ECMO based, what I mean by ECMO based selection of cannula. If it is a VA ECMO, the flow requirement is 80 to 100 ml per kg. If it is VV ECMO, the maximum flow goes up to 120 to 150 ml per kg. So based on this, VV ECMO requires more flows, VA ECMO requires lesser flows. Coming to arterial cannula, so again, because it's in the artery, the pressure difference will be high. At a pressure drop of 100 millimeters of mercury, all these arterial cannulas which were depicted here will give you the depicted flows there, the flows which were given there. So it's also weight based. So as I said earlier, no, it's not working. Yeah. So if it is an early stage of ARDS, the flow requirement is very less. I can go for a double lumen cannula. Instead of cannulating two sides, if the flow requirement is less than 4 liters, I can select a double lumen cannula. If the flows is more than 4 on a double lumen cannula, what will happen? Recirculation. So you have an Avalon cannula commercially available. Its the sizes ranges from 13 to 31 French, percutaneously placed, but you need a fluoroscopic guidance. So you should keep it inside cath lab, or if the fluoroscopy is not there, you can give a TEE, transesophageal echo. The idea of using TE is the flow should be directed towards the tricuspid valve. Okay, that's the idea here. Drainage tip is both IVC and SVC. The return is towards the tricuspid valve. Patient can be easily ambulated. This is how it looks like inside. So it drains from both IVC, SVC, and then it gives towards the tricuspid valve. So we should be very careful in the direction of the return jet. If the direction of the return jet turns to one side, the myocardium is going to get damaged, and you will be landing up in high release of ANP, natriuresis, and all those things. So you should make sure that the direction is there, same thing. And how do you know that? Can you do a daily fluoroscopy or daily thing? So it's a Y-shaped cannula, right? It's like a double lumen tube, Y-shaped cannula. The direction of the Y should be fixed here. The other Y should be fixed. So once you make sure the flow is towards tricuspid valve, the cannula should not be rotated in any directions. The direction which is there, it should be daily monitored. So pediatric double lumen, it has sizes from 12 French to 18 also. So the minimum age or the minimum weight you can use is 12 kgs patient. You can go with a double lumen cannula. So there is one Covidian cannula, 14 French, which can be used for neonatal too. So till now we have completed based on the patient, based upon the weight, based upon the ECMOs, and based upon the disease. Now based on the cannulas. So you have different cannula tips that are available, first generation, second generation, third generation. So based upon the available cannula at your center, the flow requirements, you can select the cannulas too. So 1, 2, 3 are going to be your venous cannulas or the drainage cannulas. So wherein, that's going to be arterial cannulas. So wherein you have only one holes here. If you can see, the first cannula has got only one hole, the second one has got 2, third one has got only more than 3 holes. The last 2 cannulas were the recent generation cannulas, where you have drainage from both at the end and at the multiple holes here. The whole idea of keeping multiple holes is there should not be any reshattering, there should not be any shattering, or there should not be any cannula blocks and all. It's just like your Murphy's eye in ET tube. So having much more holes will have much more extra protection here. So the last cannulas or the recent cannulas, every one of us are using this 5 and 6. It's a multi-staged and a multi-stage interrupted cannulas also. So the 6th cannula will give you maximum flows here. So all these cannulas were reinforced ones. So this is the cannula which I am talking of about. So if it's an isolated right heart failure, okay, when there is a hemodynamic compromise, it's an isolated right heart failure. There is a cannula called as Protect Dio cannula. The cannula is placed from the IJV, goes into the RA. From RA to RV, it goes into your PA. So it sucks blood from your RA and gives back to your PA. It's just acting like an RVAD. It's supporting your right ventricle. That's the idea here. So the simple thing, just to remember for everyone of us too easy, a patient weight more than 60 kgs, a drainage cannula should be 29 or 25. 60 kgs less than that, 23 will be good. The tip should be sitting at IVC and hepatic veins confluence. So why it is in hepatic IVC? Anyone can? Delegates? What's the idea of keeping the cannula in IVC? So it's a least compressible part of your whole IVC. The remaining IVCs are completely compressible. So hepatic IVC is the least compressible, wherein gets support from the peripheral liver structure. Coming to return cannula, more than 60 kgs, 21 French, less than 60 kgs, 19 French. So the tip should sit in the RA and SVC junction. Okay. Same peripheral VA ECMO, more than 60 kg. Drainage cannula is not going to change. When it comes to return cannula, the arterial cannula return, when it is a VA ECMO, the size is little bit lesser. I don't want to get my artery to go into spasm and cause limb gangrenes. So wherein we will keep a distal perfusion cannula, minimum of 7 to 8 French to get a flow of 150 ml per minute. And the original perfusion cannula is around 19 French for an average sized adult. Okay. So coming to initiation technique. So what everyone should have a checklist before initiation. So how much ever your center is experienced, you need to have a written consent. You should plan the individual responsibilities. You should divide yourself into teams. One team taking care of the patient end, one team taking care of the cannulation, one team taking care of the circuit, and keeping a CVP and arterial line. So we always advocate that without a central line and without an arterial line, better not to go for ECMO because the hemodynamic changes are very dynamic here. Better to keep a left IJV. And then that left IJV should have an extension, so he should not be coming close to the patient, 100 centimeters extension. Whenever you say bolus, he should be giving the bolus from the other end because the whole patient is draped, right, while cannulating. Blood products should be kept ready, fluids, anyhow it will be there. You need to have an ACT machine and ABG machine ready on the bedside. Inotropes, heparin, drugs, emergency drugs should be kept ready. Intubation set, if the patient is awake, in case if you are trying an awake ECMO, preferably I say no, but institutional practice varies. So ECMO machine, it should have a primed circuit, you need to have an extra guide wire, dilator set, line clamps, and a surgical backup team. You should always have a surgical backup team. So these are the routine dilators which we use for cannulations. In our center, we use urethral dilator sets also. It has got its own advantages. And all the cannula related, circuit related parts to be kept ready. Yeah. Now how to forward this again, it's a big video. So we are taking a femoral puncture. So once the femoral puncture is done, the technique is going to a simple Seldinger technique, sequential dilatation. So guide wire goes in. Once the guide wire goes in, one guy will be assisting in doing a trans-thoracic echo, seeing that guide wire should not hit your RA and get. इसको forward नहीं कर सकते. नहीं तो next जा रहा है sir. This is not working. Next बोले तो it's going to the next slide. हाँ अच्छा सी okay. हाँ से कर रहे हैं so. Shall I come there? So simple your central line technique, nothing new in this, but only thing which is extra in this is going to have multiple dilators which is sequential. You have dilators ranging from 8, 10, 12, 14. Don't miss any step. While dilating it, you need to increase the skin puncture site also with a 22 or 11 size blade. So that's the only thing here. And every step make sure the guide wire is not kinked and the backflow is there. Take it, chalo. I think it's a huge video here. So this is once the cannula is inside, make sure the blood flow is there. Clamp both the ends. This is the one which is being clamped. No? That's going to be the circuit end. The other one which is clamped already is the jugular cannula. Once both the cannulas were clamped, they are checking for any air bubbles. Yes. Once it is completely primed and bubble free, they'll release from both ends. Little bit of blood will go from here and fluid comes from here, they'll attach it. So they'll again check once the, once the circuit and cannulas are completely bubble free, they'll going to start the ECMO. They'll release the clamps, then start the ECMO. If it is a VV ECMO, minute bubbles are fine, accepted. But if it's going to a VA ECMO, it should be absolutely bubble free. There's no exceptions here. So they release the clamps from both sides, and they're going to start the ECMO. And once you start the ECMO, make sure you have seen the good color change from the venous end, dark red, to the arterial end, the bright red one. You'll see the blood coming from here. Come on. That's the idea behind the cannulations. So, kitna time le rahe? So we'll start, once you start on ECMO, we'll start it only 1 liter per minute flow, so the time takes there. So you can get the blood, complete blood here. So make sure the color change, there's a bright red color. This is a jugular side, and the side which was showing before is the venous side. So coming to the cannulation steps, you have seen the videos right now. Preparation of the patient, keeping a bolster under the hips so that the venous, the femoral venous, the natural pathway of the femoral vein should be straightened. You cannot keep the patient in his normal supine position and go for cannulation. You'll be always having a hindrance at the inguinal ligament side. You should always keep the femoral joint hyperextended a little bit so that the femoral vein will be straightened. That's the easiest way to do. Preparation, scrubbing and draping, approach. So whoever is doing what's the job? So femoral cannulation team and the jugular team should be separate. Ultrasound, puncture, pass the guide wire. Once the guide wire is in, you need to give a heparin bolus, targeting an ICT of around 250 to 300 around. And then serial dilatation technique, insert the appropriate cannula, connect to the circuit, avoid the air bubbles, secure the cannula. So that's the basic steps. So once that is done, what are you going to do now? Confirming it. So how do you confirm the cannula position? So you have an ultrasound, you have a chest X-ray, and you have fluoroscopy. Simple thing is marking on the cannulas. So this is an ultrasound showing the cannula tip is little bit deeper. This is also video. The cannula tip which was supposed to be in the IVC and the hepatic vein confluence, but it was little bit or 3-4 centimeters deeper. So you need to pull out the cannula a bit. That's playing. So this is the one. It was little bit deeper here going. So the cannula tip ideally should be located here. So the advantage of multi-staged cannulas is you have multiple holes here also. It's not going to block your hepatic vein, causing a hepatic congestion. The older cannulas has only cannula holes at the tip, wherein your cannula, the liver will get congested immediately after ECMO cannulations. X-ray, yes. You see this X-ray? They are very much near. So you need to have at least 10 to 15 centimeters difference in the cannulas, the jugular and the femorals. And see this X-ray? I cannot see the femoral cannula here. They are very much far away apart. So this patient is going to have higher chance of a cannula coming out of the patient. This patient higher chance of a recirculation because very much close. So this is one way of confirming. Can anyone say what is this X-ray showing off? What are these cannula tips? It's a central ECMO. It's a central VA kind of ECMO, wherein you are seeing one cannula draining from your RA and the other cannula going into your aorta. So it's a central VA ECMO. The central VA ECMO is nothing but a similar VA ECMO. The configuration is not going to change, only the drainage sites are going to be changed. So and the flows, when the flow requirement is very high, you'll go for a central VA ECMO instead of peripheral. So these are the various sites of cannulations available: venous, IJV, SVC, IVC, femoral vein, subclavian, RA. These are the various sites available for venous. Arterial, you can use aorta if it is a central ECMO. Femorals were not there, you can go with axillary approach. You can go with subclavian and common carotid for children. So this is a central VA ECMO, wherein the cannulas comes out like this, from here and from here. It's a peripheral VA ECMO. And again, the VA ECMO, cannula comes from the femoral vein, goes into the femoral artery, and it's a central. It's an RA and IVC, aorta. So this is a routine ECMO which we generally do. It's a femoro-jugular kind of a peripheral VV ECMO. So once the cannulation is done, selection of patient is done, selection of cannulas, flows and everything is done. What are the complications you are expecting here? So 1% of the major cannulations result in major vessel rupture. You need to have a surgical backup. You don't know when you're going to land up in complications. Hemorrhage from the cannulation sites. You need to look it for the X-ray, echo and recheck the hemoglobin in a frequent basis in the initial days. Hemodynamic deterioration is one more thing. Once the patient goes into a hemodilution kind of scenario, say for example a pediatric patient whose blood volume is hardly 1.2 liters, if you are going to dilute with 700 ml of ECMO blood volume, there will be hemodilution followed by bleeding. So conversion from VV to VA ECMO, how many of you have encountered this? VV ECMO, cardiac arrest, CPR, converting into VA ECMO. So you need to be prepared for this also. So to have the preparation, the surgical support should be available and you need to be prepared for converting into VA kind of ECMO, especially when you are initiating ECMO out of your hospital. So it's a remote ECMO initiation. You start on VV ECMO, initially, immediately the patient has a cardiac arrest. So what is your backup now? You don't have an extra cannula, you don't have an extra dilator, you don't have a connector to convert into VAV ECMO. So complications which include cardiac arrhythmias, pericardial tamponade is the most common reason causing cardiac arrest, post VV ECMO, especially when it comes to MAC-A cannulators. How many of you has done with the MAC-A femoral vein, femoral drainage catheters? So MAC-A has got a very long tip of the dilator here compared to biomedicals and all. That long tip is around 10 centimeters, which we technically think that the markings are at 44, but you are actually at 54. Coming to biomedicals, the markings are at 44, you will be at 45 or 46, that's it. So higher chances of pericardial tamponade with the MAC-A, but it's easy to insert. Saying that, I'm saying it's also very easy to insert. Biomedicals is very difficult to insert. Air embolism, pneumothorax. So selective cannulations of other vessels. You will be thinking that you are in the IVC, but it might went somewhere else. Sometimes it might shear your IVC, false passage. If you don't see the blood from the femoral drainage catheter, what do you want to do? Remove it and replace it? How many of you have tried that? So whenever you see there is no backflow from the femoral cannula, don't remove it. Call the surgeon, open the abdomen. It might have went through the IVC into the peritoneum. The minute you pull it back and try to reposition, hemorrhagic shock, and by the time you realize patient is already in cardiac arrest. So if you don't find a backflow from any cannulas, don't remove it. Wait, call the surgeon, open it up and see. Cavitations, air embolism, cannula kinking and hemolysis are the complications. So to prevent all these complications, every ECMO running center should have a checklist like this, wherein they will monitor the RPM, LPM, pre-pump pressures, post pressures, delta pressures. Everything should be monitored and the trend is much more important rather than the absolute values here. In ECMO, it's a test game. It's never going to be 20-20 or 50-50. You need to have the patience, monitor carefully, then only you'll have good outcomes here. So what are our preparedness? So once done, you know the complications. What are our preparedness? So as I said, no, one central line should be separately kept. Don't initiate ECMO on a peripheral lines when the patient is on peripheral IV lines. Keep all the drugs loaded. You don't have time to load again. So keep the adrenaline, atropine, soda bicarb, calcium gluconate, all the drugs loaded and kept ready. Let it be wasted.
Sir, but last 2 minutes.
Yeah,
remaining.
please, done, I'm done. So keep a Vigon ready. Why Vigon? Anyone? If it's a pericardial tamponade, immediately you need to give a pericardiocentesis. Keep a Vigon ready and keep an extra femoral arterial line of 19 French or 21 French ready with you. So in case of cardiac arrest, you can convert it back. That's an arterial cannula. The simple idea for all this is ECMO crash cart, wherein it has got extra of everything, a guide wire, a dilator, extra cannula, extra femoral cannula. We don't know which complication is going to come. You need to have an extra set of things wherein you can initiate an ECMO again. So ECMO crash cart is the answer for all your complications. So I'm concluding this here. The success depends upon how you are going to select the patient, when you are going to select the patient, and how you are going to take off. Proper selection, right time initiation, avoiding the complications, and the team approach. You can never think that I am the hero here, I can do all the things. You need to have the surgical backup team. You need to have an expert team in your backup supporting you. Thanks a lot. Any doubts? I'm ready to take.
Hello.
Yes, sir. Sir? Intracranial pressure. So it depends upon sedation interruption, sir. First 2 or 3 days, we are not going to awaken the patient. One is your pupillary reactions. If you have a TCD, so you can do a TCD. If you want a TCD. Third day, by around second to third day, we'll stop the sedation and see his awakeness. Patients, most of them is conscious, obeying, moving all four limbs, I'm happy. If there is a deficits and all, you can do a CT scan also. But you cannot do an MRI on ECMO. It's only CT. Yes, ma'am, please.
Hello.
Mic, please.
I request delegates to ask the questions during workstations, please, as will be running in a very tight schedule. So I request you to note down your queries pertaining to that particular faculty, and then that can be discussed at a workstations, because we have a 30 minutes at each workstation. Thank you.
Madam has got something to
Madam.
say. One word to say, it seems, ma'am.
The ICP, actually I feel the optic nerve sheath diameter
Yes, ma'am.
is the simplest,
Simplest.
which is done at bedside, and we have written papers in first time in India. So I think that is one thing which helps you for your reference. Okay.
Yes. Thank you, guys.
Thank you so much, sir. Our next speaker will be Dr. Rashmi Agrawal. She'll be discussing various trials in ECMO.
दो सेकंड रुको। इधर ही कनेक्ट कर देता हूँ। थोड़ा लैपटॉप उठाते ना।
I don't.
Good morning, everyone. As we are already running short of time, and my topic being trials and ECMO, which almost everybody must have read, so we'll go little quickly on this topic. So, starting with Caesar trial, it is a trial about conventional ventilatory management versus extracorporeal membrane oxygenation for severe adult respiratory failure, a multicentric trial done in UK between July 2001 to 2006. They recruited 180 patients, of which either 90 patients received conventional management and other 90 patients receive ECMO. Majority of them has pneumonia as a cause of respiratory failure. It was designed to study death or severe disability at 6 months after randomization. The inclusion criteria were pretty simple: severe but potentially reversible respiratory failure, Murray score, as Dr. Rakesh has already told us, of 3 or more, uncompensated hypercapnia with pH less than 7.2 despite optimal conventional ventilation, and age between 18 to 65 years. Exclusion: patient ventilated for more than 7 days with high peak and high FiO2 requirement. They have signs of intracranial bleeding, contraindication to heparinization or planned limitation of support. The conventional management group has to be hemodynamically stable with pressure restricted to less than 30 centimeter of water, PEEP titrate to optimal saturation, FiO2 to maintain saturation more than 90%, diuresis to dry weight, PCV of 40%, prone positioning, optimum nutrition. Transition to ECMO was done when they were non-responding within 12 hours. Their saturation was less than 90% despite FiO2 of more than 90%. They have respiratory or metabolic acidosis. They were hemodynamically unstable. ECMO management: all were transferred to single ECMO center in UK. No patient transferred on ECMO, VV mode with percutaneous cannulation. They use servo control roller pump, polymethylene pentene oxygenator, Siemens Servo 300 ventilator with rung rest setting, which include PEEP of 10 to 15, pressure of less than 30, RR of 10, and FiO2 of 0.3. The ventilation and ECMO were continued till recovery or irreversible multi-organ failure. The primary outcome was death or severe disability at 6 months. Severe disability was defined as confinement to bed or inability to dress and wash alone. 90 patients acquired to receive ECMO, 3 died before transplant, 2 died in transit, and 85 arrived successfully. 17 patients were treated just with the ventilation alone, of which 14 survived, and 68 received ECMO, of which 43 survived. So the results, when we compare between the ECMO group and management group, death or severe disability at 6 months was 37% in ECMO group and 53% in conventional group, and less than 6 months patient died or they died before discharge with 37% in ECMO group and 45% in conventional group. Severe disability was reported only in 1% of patients in conventional management group, and majority of them died due to multi-organ failure. The secondary outcome were comparable between the two groups in between requirement of prone position or nitric oxide. However, steroids and molecular absorption reabsorption technique, which was used in liver failure, were more in ECMO patients because the duration of stay was long. So total duration of stay in ECMO patient was around 24 days, whereas for conventional ventilation 15 days. So as we discussed, ECMO becomes a valid treatment for severe respiratory failure. Significant improvement in survival without severe disability in patient transferred to ECMO center. 6-month follow outcome also favored ECMO. Mortality alone was also lower in ECMO group than in conventional management group. However, study was not powered to detect this outcome, and this difference did not reach statistical significance. 5 patients in ECMO group died before or during transfer. Mobile ECMO might have helped for the positive results. Now, moving on to the next trial, which is an EOLIA trial, ECMO to rescue lung injury in severe ARDS. It was published in NAGM 2018. It is also a multicentric RCT, predominantly in France. They were randomized at 72 hours of ventilation. ARDS definition as per their time American European Conscience Conference, endotracheal intubation should be of less than 7 days, and they should have either one of the below. PF ratio less than 50 mmHg for greater than 3 hours, PF ratio less than 80 mmHg for greater than 6 hours, or pH less than 7.25 with PaCO2 more than 60 mmHg for 6 hours. Exclusion criteria include who were ventilated for 7 days and many others, of which common are chronic respiratory failure, cardiac issues, cancer, and irreversible neurological injury. The intervention group received percutaneous cannula, which assess cannula in femoral vein, return cannula in jugular vein. They used Mackay CardioHelp device as a ECMO machine. Pump and oxygen blender were used to achieve saturation greater than 90%, and ventilation was adjusted to achieve partial pressure of CaO2 less than 45 mmHg. Ventilation strategy, as per ARDS net protocol, they used volume assist or bilevel positive pressure ventilation, anticoagulation with heparin, or in heparin-induced thrombocytopenia with direct thrombin inhibitors like argatroban. Rescue ECMO. The patient received rescue ECMO when, despite conventional ventilation, they have high plateau pressure, higher driving pressure, lower respiratory compliance less than 25, more infiltrate in chest radiograph, PF ratio less than 51 mmHg, saturation of less than 80% for more than 6 hours, increased vasopressor requirement. However, the patient becomes severely ill during this decision, and out of which 9 had cardiac arrest, 7 had RA failure, 11 had renal failure leading dialysis, and 7 needed to be initiated on VA ECMO because they required eCPR. So when we compare the results between the two groups, mortality at 60 days were almost comparable between the two groups, did not achieve the p-value of significance. However, treatment failure at 60 days achieved the p-value of significance. The free from mechanical ventilator days was more in ECMO group than in control group because of the survival benefit little achieved in the ECMO group. So 60-day mortality was higher in crossover patient. As we have already studied, they have been very ill before the initiation of ECMO, and that's why they have a higher mortality, about 57% as compared to remaining controls. So 28% in control group crossover to ECMO for refractive hypoxemia interfered with the definitive conclusion. Higher mortality in crossover patient. Trial recruitment was stopped after 75% of maximum calculated sample size as planned as interim analysis show no statistical significance, and trial was thus underpowered to detect mortality. That was 20 percentage points lower in ECMO group than in control group. Now moving on to another trial, which is a REST trial, which is trial on ECOR. It is a low total volume ventilation with extracorporeal CO2 removal versus standard care ventilation on 90-day mortality in patient with acute hypoxemic respiratory failure. It is a multicentric RCT done between 2016 to 2019. They were randomized one by one as per the computer-generated schedule. It includes patients with invasive mechanical ventilation with reversible cause of hypoxemic failure less than 48 hours since the onset of hypoxemia, and they have PF ratio less than 150 mmHg requiring equal to or more than 5 cm of PEEP. Exclusion criteria as for all other cases, it was more than 7 days of ventilation. Clinician able to reduce tidal volume less than or equal to 3 ml per kg without requirement of ECOR. Any contraindication to anticoagulation or heparin, untreated pulmonary embolism, pleural effusion or pneumothorax, or signs of LV failure or fluid overload. They recruited 412 patients. Baseline variables were balanced. Intervention were dual lumen ECOR catheter with heparin anticoagulation, higher blood flow 350 to 450 ml per minute, and sweep gas removal was turned to 10 liter per minute. Tidal volume of 3 ml per kg of Brodivect, maximum duration of use for 7 days, and control arm received ARDS net ventilation strategy. However, the study wanted to achieve the ARDS net trial mortality benefit of 9%. Therefore, the trial was stopped after recruiting 412 patients, as that analysis suggested only 44% chance of finding a difference. Trial thus stands underpowered and could have missed a true difference. Primary outcome was no mortality benefit at 90 days. However, less ventilator feed rates for ECMO group and no difference in 28-day mortality and ICU and hospital length of stay. Now, this trial is under recruitment. It is an early versus late initiation of ECMO trial, a very important trial. Not yet to be published. They are going to discuss about 28 days and 90 days all-cause mortality in ECMO as a primary outcome, and other outcomes will be SOFA score, risks of delirium in patients who have been receiving ECMO, and discharge location, whether they have been discharged post-ECMO to home, nursing home, rehabilitation unit after 28 days or 90 days after discharge. Moving on to VA ECMO trials, we have one major trial in VA ECMO, which is an extracorporeal membrane oxygen therapy in cardiogenic shock.
Ma'am, 5 minutes left.
Yeah, so as per the European Society of Cardiology, mechanical circulatory support should be considered for hemodynamic stabilization patient with cardiogenic shock, and European Society also favors the statement. The study was designed to study any death from any cause, implantation of any another mechanical circulatory support, or resuscitated cardiac arrest. They excluded all other causes of circulatory shock and cardiac arrest survival, including patients whose arterial cannula cannot be inserted. The discussion, death were comparable between the two studies, and another mechanical circulatory support was required more in the conservative group. The trial was thus underpowered, and almost 39% required downstream VA ECMO as a support mode, which made the interpretation of result difficult. So the trial basically compared VA ECMO with bailout VA ECMO rather than the conservative management, and strategy of unloading left ventricle were also not predefined, which led to worsen outcome. Moving on to another trial, which is an ECLS shock trial recently published in NAGM 2023 August article. It is an infarct-related cardiogenic shock role of extracorporeal support. In this patient, they initiated ECMO before undergoing the coronary revascularization plus medical management, and control group received only medical management. So inclusion criteria were patient with cardiogenic shock treated with PCI or CABG, and they excluded patient who have mechanical causes of shock and received CPR. Crossover, however, was avoided, but they allowed IABP and transvalvular microaxial flow pump as per the predefined criteria. The ECMO ideally commenced before PCI, maximum flows were targeted, distal perfusion criteria were encouraged, and 17% patient does not receive ECLS for technical and clinical reason. Control predefined criteria for escalation to IABP or microvascular flow left ventricular assist device cause over to ECMO, however, happened in about 28 patients. So in this group, as being on the patient who have been revascularization, they have more risk of bleeding and risk of ischemic complications in the ECLS group. So the liberal inclusion criteria, unselected implantation have lead to the unfavorable outcome. Also, many of them receive CPR prior to randomization, which led to overall bad prognosis. Other important trial are Euroshock trial, which is yet to complete its data due to COVID-19 pandemic. However, it was an important trial which showed promising result for VA ECMO patient after primary PCI was been done. And another trial is under recruitment, which is VA ECMO with IABP support for LV unloading versus optimal medical management in cardiogenic shock. So lesson learned from this trial, which is a take-home messages from us. Conventional ventilatory management in ARDS to target low pressure, low volume ventilation had promising result if lung mechanics allows. ECMO with ultra-low tidal volume ventilation strategy has less 6-month disability as compared to conventional management group as per the EOLIA trial. ECMO has greatest advantage when initiated early, not to be initiated after 7 days, and better if initiated within 72 hours of randomized mechanical ventilation as per EOLIA trial. Majority of patients had crossover to ECMO after failing conventional management, confounding the interpretation. Too sick to transfer patient should be initiated on ECMO and then referred to ECMO center, ECMO on wheels. Cost effectiveness can be improved if we reduce cost of both transport and provision of technique. So early transport of patient to ECMO center should help. Sample size used in many RCTs are small and needed bigger trials to generate outcome. ARDS net trial in ARDS changed the way we used ventilator. With increasing use, more sample size, ECMO management will be more protocolized. Thank you, everyone.
Thank you so much, ma'am. A very warm good morning to esteemed guests, dignitaries, and delegates. We are gathered here today for a momentous occasion, the lamp lighting and inauguration ceremony. This is Central India's inaugural ECMO workshop. We are honored to have Dr. Manimala Rao, Dr. Lalit Wagmare, and Dr. Rajkumar Khandelwal with us today. The lamp lighting ceremony is a time-honored Indian tradition symbolizing wisdom, knowledge, and guidance. As we lamp the light today, we ignite the spirit of learning, progress, and move forward into this venture.
Now, I would like to invite our guest, Dr. Manimala Rao, Dr. Lalit Wagmare, Dr. Rajkumar Khandelwal, Dr. Rajan Barokar, Dr. Virendra Belekar, Dr. Rashmi Agrawal, and all other faculties to join us for the ceremonial lighting of the lamp. Let this deed serve as the start of a new endeavor and turning point in the treatment of the emerging ECMO modality.
Hello. We are privileged to have Dr. Rajan Barokar here to share their thoughts and insights on this occasion, as well as the strategy and goals for the upcoming year, that is ARDS ECMOCon 2024. Thank you, sir.
Good morning, everyone. Good morning, everyone. It took a wait of almost 21 years after I witnessed my first ECMO procedure at Loyola University. So we did almost 18 to 20 ECMO in last 2 years, and this joy came 2 years back during COVID times when our team member, Dr. Afzal, he initiated a first ECMO at our center. However, we needed to know more and learn more for understanding patient selection, monitoring, and better outcomes. Well, this 4th December, we celebrated 4th year of Kingsway Hospital, now KIMS-Kingsway Hospital. And I thought our first activity should be that which has actually driven me and us to shift to an institution from our private small hospitals. And hence here we are. We are welcoming my mentor and teacher and today's chief guest, Dr. Manimala Rao, Madam, for the first ever ECMO workshop in Central India at KIMS-Kingsway Hospital, Nagpur. I am feeling overwhelmed with the presence of our guest of honor and my friend Dr. Lalit Wagmare, who is a Vice Chancellor of DMIMS University, Varda, Dr. Rakesh, Dr. Prabhat from Hyderabad, Dr. Munish and Dr. Pooja from Fortis, Gurgaon, Dr. Raju Khandelwal, Managing Director of Kingsway Institute of Health Science, Dr. Tushar Gawad, our COO, Dr. Imran, whom I am missing right now, who is the chairman of SCCM, my intensivist colleagues from the city, and my clinical and administrative and most important, all the delegates for this workshop. So I welcome you all for this workshop, and I hope you all will enjoy this workshop, and I want you to utilize this presence of esteemed faculties from all over India and make a maximum utilization of their knowledge and learn maximum hands-on thing, as we have luckily arranged ECMO machines, the catheters, the cannulas, and every possible things that is needed to learn more about the ECMO. Once again, I welcome you all for this workshop, and I hope you will all enjoy it. And I thank you, all of you, for being here. Thank you.
I would like to invite people to the platform for the felicitation now. Vice Chancellor Dr. Lalit Wagmare to be felicitated by Dr. Rajan Barokar. Chief guest Professor Dr. Manimala Rao to be honored by Dr. Virendra Belekar. Guest of honor Dr. Rajkumar Khandelwal to be honored by Dr. Rashmi Agrawal. Now I would like to call Dr. Rajkumar Khandelwal on stage to say a few words on this special occasion.
Good morning, everyone. Respected Ma'am Manimala Rao, our chief guest, Vice Chancellor Dr. Lalit Wagmare. I know it may be looking formal to him, but as you know, Vice Chancellor is the head of the land. So his presence means a lot for us, which is really symbolizing any academics are giving a good seal. So thank you very much, sir. You are here. Indeed, we are so overwhelmed and so happy to see this particular day. ECMO is one very modern technology which is being used now in and out everywhere, which is the most life-saving technology which is there. And organizing a workshop and a session for this particular thing to enhance the knowledge, to cater to all scientists, all the critical care people in this region to see the thing that it should become a routine, it should become available everywhere. Taking this step forward, I really congratulate the team headed by Dr. Rajan Barokar, Rashmi Agrawal, Virendra, and the management team for organizing such a wonderful activity. Here I would like to just say, no hospital can do better, which Dr. Wagmare will always appreciate and say that. No hospital will do better until unless it has got a great and robust academic wing. And we are very happy to see that this hospital has got a wonderful academic wing, right from all the fellowship courses, DNB courses, all the courses, all the training program of Royal College are existing in this hospital. This all has become possible for two things. One is the interest of our own consultants, which is really, if I say the few name, one of the leading name is Dr. Rajan Barokar for starting this academic activity in this particular hospital. And that's why the result, the clinical result of any hospital will largely be depend on when you are having a wonderful residents. And here I won't forget to mention a very special mention of Dr. Lalit Wagmare sir. He has helped us for creating the academics in this hospital to an extent that he has given or taken a very special permission, which is under one of the bylaws of Medical Council of India, by posting the residents in this hospital, residents who are doing MD/MS. When we were aspiring in the beginning to have the good resident, he has shown us the light. So today, his presence in this program means a lot for us. And we are looking forward to you, sir, for giving us these kind of a guidance and support all throughout the time. I really welcome all of you here today for this particular unique workshop activity, and I'm sure in a couple of days deliberations, this is going to take a long way ahead in your career. All the best.
Hello. Now please welcome Dr. Manimala Rao to the stage to share a few words on this momentous occasion.
Can I say from here? Yeah, I think so. Very good morning to all of you, and thank you very much for inviting me here for this workshop. Well, nostalgically, when I go back, years back to, it has started with cardiac anesthesia, because we were very much involved. When the surgeons are putting, we would also say, give me a chance, I want to do, such things. So, and after the bubble oxygenators, which we had, then the membrane oxygenator came little later. But then we have seen all that, and then the ECMO, whatever it is, with that machine, with the membrane oxygenator, we used to carry, some of them were not coming off the pump, to the post-operative ICU. So that is how the interest was there for me. But it is unfortunate, I have, by the time COVID came, I almost left the clinical activity. But anyway, I still feel very happy, as he very rightly said, that if you have the academic activities, it keeps us going in large strides. And the students make us feel that every day we have to learn something more to teach them. That is the basis of the academics. So when I'm also part of KIMS family, so I am at the Hyderabad KIMS doing the academics, director, education and academics. So that is what I'm pushing some of the students. Dr. Sambit Sahu is also one of my students. So he does a lot of good work there, and he has built a great team. That is what is the most important thing. If you think it's not a team, then you cannot do anything. If you think it's a big team and all my team members are equally important for us, that's what is the success. The team wins in the end. So how you look after the team is for you to think. That is the thing. Thank you.
Thank you, ma'am. To deliver a few remarks on Central India's inaugural ECMO workshop, I would request Dr. Lalit Wagmare sir to come on the stage.
Good morning, everyone. Dr. Manimala Rao, ma'am, a legendary teacher, academician in the domain. My elder brother, Dr. Rajan Barokar, sir, whatever I am today, I think 60-70% I have been shaped during my younger days by his advice, or I would say learnings from him. Uh, my teacher again, Khandelwal sir, all my dear friends sitting across, Viru, Anant, uh, and the wonderful delegates who have come here. I could listen to a couple of lectures from Dr. Rashmi and Ramesh sir. Uh, I mean, this is a very focused workshop on ECMO. Let me first congratulate Rajan sir and the whole teams of KIMS-Kingsway Hospital for organizing such advanced workshop in a city where these advances are rarity. So KIMS-Kingsway is again a torchbearer in bringing the latest healthcare technology to this region. And I congratulate the whole team of Kingsway also for that particular event. I have two little submissions during this workshop, since this is a workshop which is very focused, and technically I am sure the deliberations will be world class. I have no doubts about it. Only my request is that during the COVID period we have seen, even if the doctor is ready, we have to have the team built up in the same spirit and same level. So whether it is nutrition, whether it is support manpower which is there, technicians, nurses, as sir was mentioning, there has to be a crash card created. But who will run that crash card, sir? For that also we will require a lot of training to those team. So just as the technical expertise of the doctors is important, the technical expertise of the support manpower is also equally important. So I would request sir, madam, everybody to conduct some similar kind of workshops and activities for that team as well, so that we come as a team. I was in Sydney for a delegation of few universities, and University of Sydney does very good program of Sydney professional certifications. So those professional certifications are meant for people like us. So there is a retrieval certification. So organ retrieval is another big domain which is coming up with the transplants coming in this thing. So retrieval certifications for nurses, retrieval certifications for paramedical staff. So if we can, with the academic wing very strong at Kingsway, we can start certain certifications for these manpower, then I think we will be building the team over a period of 5 to 10 years. As we see, robotics has taken over, AI will take over, ECMO will have technological changes over a period of time. So similarly, we will require the support manpower also to be trained on those lines. This was just a humble suggestion from my side. Of course, you are doing a very good job for the society in building up these kind of setups in central India. Also, there is one thought for food is how we can reduce the cost of consumables. We cannot reduce the cost of equipments or manpower, which is very important. But consumables can be worked on. Like I was just discussing while with my colleagues when I was in Shanghai, the liver transplant cost in Shanghai is nearly 3.5 lakhs. Which is like 1/10 of the cost which we are doing right now. So that is why I'm not saying that we have to do anything and everything to do for reducing the cost, but yes, the consumables, the kind of daily expenses that the stakeholder has to face, if we can reduce on those costs, it is a cost to everybody, cost to the society, cost to the environment, because it is not a sustainable way of having many, how we can go sustainable, zero carbon neutral. All these issues are also important, and they should also be given some thought for food. And again, I'll just give one more example and quit, because I think there are many wonderful deliberations which are there. Massachusetts Institute of Technology has a medical wing. Ophthalmology, head of the department, is a man from physics background. So there is no such integration between clinical engineering and medical care as far as India is concerned. Now the time has come that we as doctors should put in our efforts and should put in our thoughts in coming up with solutions which are technology based. So that is another area where all of us have to think and work. And of course, with the people and mindset, I'm sure, since I know Rajan sir for last almost 20 years, and I know he has these kind of thoughts, and I'm sure everybody working with machines, be it a robotic surgeon, be it a hepatic transplant surgeon, or intensivists like you all sitting here, have lot many thoughts that how we can reduce the time, as sir was mentioning about two kinds of catheters. So Mackay gives a particular way of catheter, and biomedical he was mentioning. So how we can go precise? No engineer will be able to do it, sir. We have to tell our requirement, then only technology can come in and get the things worked out. So we have to work on these lines as well. This was just what I could say, and I immensely thank Rajan sir, Khandelwal sir, Madam Viru, everybody for giving me an opportunity to interact with such stalwarts who are there in the field of intensive care. And I wish the workshop all the very best. Also, if there is anything which I can contribute to as academic institute, we would be very happy to be partners in developing skill sets, developing programs which can help all these activities go to the masses, not to the select few. Thank you very much for the opportunity. Thanks a lot.
I would like to invite guest of honors to the platform to receive a token of appreciation. Vice Chancellor Dr. Lalit Wagmare to be honored by Dr. Rajan Barokar sir.
Chief guest, Professor Dr. Manimala Rao to be honored by Dr. Virendra Belekar, sir. Chief of Guest, Dr. Rajkumar Khandelwal to be acknowledged by Dr. Rashmi Agrawal. Now let's resume back to our lectures.
Yeah, vote up. Ladies and gentlemen, on behalf of Department of Emergency and Critical Care Medicine, KIMS-Kingsway Hospital, I extend my heartfelt gratitude to each one of you for extending your participation on this workshop on ECMO. Our special thanks to our chief guest, Dr. Manimala Rao Madam, Director Medical Education and Academics, KIMS-Kingsway Hospital, Dr. Lalit Wagmare sir, Vice Chancellor, DMIMS University, Savangi, Varda, Dr. Rajkumar Khandelwal sir, Managing Director, Kingsway Hospital, Nagpur, Dr. Tushar Gawar sir, CEO, Kingsway Hospital, Nagpur, for sparing your valuable time and enlightening us with your words of wisdom. Our sincere thanks goes out to our distinguished speakers and presenters who shared and will be sharing their valuable insight and expertise enriching our understanding of ECMO. Special mention to our faculties, Dr. Rakesh, Dr. Munish Chauhan, Dr. Pooja Vadwa, Dr. Prabhat Datta for constant guidance and help needed to conduct this workshop. Special thanks to all delegates for your zeal for constant upgradation in knowledge as we welcome few delegates from different parts of India also for this workshop. Your passion and commitment to advancing knowledge in ECMO is truly commendable. We express our appreciation to our guide and mentor, Dr. Rajan Barokar sir, Head Department of Critical Care Medicine, KIMS-Kingsway Hospital, for having his vision to conduct this first ECMO work conference in Central India and his unmatched dedication and efforts to make it a success. A note of gratitude to our Master of Ceremony, organizing committee and volunteers of KIMS-Kingsway Hospital who work tirelessly behind the scene to ensure seamless logistic and smooth flow of the events. As we conclude this inaugural function, we are looking forward to academic feast and hands-on experience in today's workshop. Hope we carry with us the collective wisdom and look forward to future collaborations, continued dialogue, and positive impact that will undoubtedly arise from connection forged here. Thank you once again for being an integral part of this transformative process. Yeah, and taking this as an opportunity, I will like to announce the similar workshop on ECMO, which will be organized in much bigger scale and with much better concept next year on 6 to 8 December 2024. We will like to welcome you all once again for that conference as well.
Now let's get back to our lectures. Our distinguished speaker for the upcoming topic is the esteemed Dr. Manimala Rao ma'am. She will discuss the establishment of ECMO unit, emphasizing important factors and challenges encountered during the setup process. I request delegates to jot down questions, any questions they have, and that will be addressed and resolved at the workstations.
Mic, this one, confusion for a older lady, huh?
No, we will get it sorted, ma'am.
It's okay. Agya. Thank you. No more technical, problems. So anyway, let me honestly tell you today, after many years, or almost I think it may be the first time, I'm talking on somebody else's slides, okay? Normally, I make my own slides. Usually, I will put whatever my thought is there. So this, my student, Dr. Sambit, asked me last night, when I was almost in the flight, saying that, Madam, I am not able to come. Can you please tell this? Well, I can't say no to a student or to a patient. So this has been me, okay? So I said, okay, I'll try and do it. And then when I looked at the slides, how to establish an ECMO unit. Well, though I have worked with ECMO, I have seen some of it, but totally establishing an ECMO services is a little different today, a different ball game today. So why do we really need to establish these services? So what are the most important thing, as I said, you need a team of dedicated people who are in the critical care, who can draw all others for the ECMO services, okay? Because you do need the surgeon, the cardiology, the other, from the emergency medicine, from various other pulmonology, all these people in and around, we do require the services. So you have to have a good setup. So how do we need the assessment? First important is, are we having patients? And in a private setup, particularly, if there are no patients, they'll throw you out, okay? So that is important, that we have to know that we have come up to that level and we have really taken care of our ARDS patients. So that is first VV ECMO. Let us not worry about VA ECMO. The cardiologist will send us to VA ECMO once we establish this, right? So what is that VV ECMO? Why do we require, and how many patients do you have ARDS? Can you tell me in your place, how many patients of ARDS, severe form, who went on to ventilator in the year? So that is the first thing you have to audit yourself. So how many patients have I treated? How I have treated? How many patients did not come out of it? And how I did the proning, I did everything, but still I could not manage this patient. So this patient, if I had an ECMO unit in my own ICU, which I can set up in one corner of my ICU, and train others where they have got already running this unit. So that way you will be able to. Anyway, you have set up, I'm just saying that for other people, so the number of patients whom you are going to, what is your resource, and how much is the hospital management agreeing. So you have to see that this is going to be, so the audit is very important before you go to the hospital management. So first of all, you identify the area in your own place. Maybe you require a larger area, at least 2 or 3 beds have to be taken out. Start with maybe 1, with a little extra couch there, in case you get a emergency ECMO, you have some place. So, and you know that it requires oxygen, it requires air, it requires suction, it requires dialysis port, and then it requires a place for the console and various sizes of cannula. And just now he was saying that you should also have a ECMO crash cart. So then you have to train people on the ECMO crash cart, on the ECMO also. So once you have something in place, the training for everyone, not just you or me, training from the technician, the nurse, the person who takes up the IMA, the ward boy, everybody has to be done with infection control and how to take care, how the nurse is going to look at every day, what is happening in the place and what is happening, who is going to look after the crash cart. So these are all important that we have to, so where you are going to put your dialysis, where you are going to put the ventilators, where is the console, everything, okay? So all the equipment is also recorded. So look at it. This is the amount of things which you require. So you require space. Do we have space? And if so, where is the space? And how much is the space needed? You have to literally look at all the space. You cannot say, I will start it and the space is only very limited. So do a lot of research into these things. Then it is also not easy. We all know as critical care people, when we do something, everything right also, sometimes you don't get the, the needed appreciation. The patient goes back to somebody else who is the primary and they get, Doctor Sahab, aapne humko bachaya. Okay, doesn't matter. We are all there to take care of patients. They will come back so there is nothing that we don't have to worry about it. So we have to have anesthesia, we have to have intensivists, we have to have a CT surgeon, because you say we don't know when we can get into problem, so we have to be friendly with them. We have to have the perfusionist, what he or she is doing, you have to understand, and the blood bank, the nursing team, the lab services, and most of the little things which we can do as a lab, you should be able to do, like TEG and things like that, can be in with us also. And even like the ISTAT, we can have it at the moment and then send it to other things. I'm just saying, these are the things which usually I look at this. And the radiologist, you want all the, and of course our ID consultant who has come and will change the antibiotics sometimes. We may change it, but we do require it with a lot of things which has, over a period of time it has. And especially our respiratory therapists, which we have started first time in India, and anesthesia technicians we have started. So these are all the people who have been trained with us. So they know what we want, and they will help correctly at the time when we require it. And they have to be trained by us also. So then the finances. So especially ECMO. ECMO is, at the moment it's pretty costly. Every day about 3 lakhs or even little more will be spent by the patient per day. So how many can afford it? Very few can afford it. That's why we have to correctly choose our patients for the ECMO at the correct time rather than late. So that is anyway understood by all of us now. Now, what is this team of ECMO? So you have to have, like Rajan sir, you can have a director who will be looking into all these areas, and he is the critical care expert and the physician, and he will also oversee, he or she, whoever it is, and the quality improvements. We have done this as it improved. This is my audit as that. So it has to be put from the beginning itself. If we want to put it late, it doesn't happen. So think of, and also some specialty training. Do you want to send some people somewhere else and then get it? Then one coordinator has to be around, a physician, a supervision and training of technical staff, maintenance of equipment, and data collection. So you must be having everything on the computer, so it is easy to collect the data. So how many of you give a discharge summary from your ICU? Discharge summary in the case sheet, written or printed? Yeah, I'm glad at least some are raising. So I used to do this way back in the mid-90s. So if you have a computer, your name and what you have done should go there. That is very important, so that when the patient comes back, for any other reason, we know what we have done. We can't keep the old case sheet, bring it and all that. So these are, so the data has to be properly collected. And of course, the specialists who are going to do the nurses, the physicians, and who run the service at bedside, it is very important. And also they should be certification and training. So if you want to start a team, lay down policies and procedures, then from certified training, you know ELSO, that is the ECMO organization, in-house training, and also the water labs, because even for your dialysis, you require a lot of RO water. And of course, as you are doing the simulation workshops now, so even there we can have some amount of simulation. You can keep it until day to day, till a new person comes, till he goes to a workshop and gets trained. Maybe we can train them in the house. So what I've sensitized, definitely referrals from the specialists. Also talk to them now and then when they should refer. I remember a long time back, when we didn't have all these ICUs, with just one bed I started my ICU. So I used to go with the physician, internal medicine, to the emergency room and bring patients if it was required for them. They were just keeping there. I said, no, the patient requires ICU admission. So like that, you have to lay down guidelines even for ECMO. When it comes, they can call us. Even if it is outside, they are not doing. Or when we ourselves are there with the ECMO, when we want to start, don't start very late. Usually I always tell, because maybe I'll take a little time, so give me as a chief guest another 2 minutes. So what is the most important thing you think between the pressure control ventilation and volume control ventilation? What is the difference? Anybody can tell me, just the difference. Volume is, you're controlling the volume, right? And pressure is variable. In ARDS, what do you want? You are looking at pressure. So, and pressure is for oxygenation, improving the oxygenation. Volume is for ventilation. So if we have that in our mind, I think I don't bother about volume control at all for my ARDS patients. I have worked with pressure control. If it is moderate or severe, most of the time I used to get a fairly good response. I've also seen some work between it. Could not publish that because I didn't randomize it. But I have seen. Of course, there are a lot of things saying there's no difference. But the thing is, you want to do oxygenation, you like to do the pressure and give a little bit 1:1. If it is moderate to severe, don't leave it, how much, then you check what is the volume. You give a little longer respiratory rate so that your PCO2 is also low. I mean, this used to be, and if it doesn't work for in 2 days, 3 days, then you have to think of ECMO. Then don't go on. Of course, there are people who show improvement. Those you can continue. I mean, this is how I looked at it at that time. And so how do you do the ECMO transport? That is most important, you're all talking. So once you are having any patient somewhere outside, the team which is here, if they are going to send, the team can go. That's used to be done earlier also. We used to go, suppose like a transplant, people go and do these things and then bring them, or they go and do the transplant there. So the thing. So that can be done and thought about. So if you have an ECMO team with all the nurse, the doctor, and whatever they do correctly, and you have all the equipment which you can take by transport. Of course, by helicopters and all, I do not know how much they can do all that, but at least by road transport, you can still manage. That's what they say. So these are the various things which can be thought of and then do. These are all, I think, the KIMS, wherever they are. And in KIMS only we had. So the patient is undergoing ECMO. You have to be very, very careful about 2 things. One is the bleeding, other is in infection. So if you get any of these, then you are not going to make the patient come out from the ECMO. It will only exit, okay? So these are the various things which you can think about. And of course, infection control, we all talk about it, but can we put our hand on our heart and say, we do it 100%? Nor do we really look at it. Sometimes the primary consultant suddenly comes and he goes near and then trying to touch the patient. What do you say? You don't say anything because he's senior, right? It happens. Don't say it doesn't happen. It happens. So always keep something in your, coat pocket. I say, wait, I'll give you this. So once I give, all my students used to do that. So start all such things, okay? And antibiotics, we are really, everybody tells the ICU people who use more antibiotics, but we are forced to do that because they are coming from district level. Meropenem comes from that level. So that is what is happening to us. So you have to educate others also. It's not us, it is coming in that way. So try and see how much is your antibiotic policy, what is your audit, what is their audit. Sometimes VAP is not recognized or not told, now that for the insurance sake, we don't call it VAP. We all know that, right? So this is, then in the transport I said, you have to have a road as well as they do by helicopter also in many other places, many other countries. So this has to come from us only. You train a team, send them. So most important is financial viability. You have to have a very clear communication with the family and convince management to do the cost to cost for some time. You tell the patient, this is the cost, because of this is the cost. So as the Vice Chancellor was saying, we have to find whether we can reduce the cost in any way. Unless you sit with these things, you cannot, because we are so busy with our clinical work. We forget these which are important, okay? So can we prepare our own circuits? And whether it is in the public sector hospitals, they may to a certain extent, but I am not sure. So these are various things. For a successful ECMO program, you have to have definitely a good team like yours, then certification from ELSO. There should be clear indications, and you should be having an excellent ICU care before you say no to that care and go to ECMO. And very clear communications with the family and an exit plan. We have to be able to tell them, well, look, it's not working. And you can take help from other centers who are doing larger numbers. And if you feel unhappy, we have not got many, you can send your student even there. And then audit yourself all the time so that we learn from our mistakes. Learning from others' mistakes is good, but learn from our mistakes also is also important. If we don't do that, both the things, then you are called a fool, right? So what you do not do, rely on external support, see one and do one. Unnecessarily indications, don't do that. Experimenting, because you have learned something quickly, you want to go to the top. Nothing can go to the top quickly. We have to climb steps, okay? And then the procrastinating, don't do that. So that, all that. So with all these things, you can definitely improve a great team and do a great work. And I wish you all the very best. In my life, I've seen a lot of things, and I am sure you will see more. But AI is going to come into your life. It's already come, okay? But be a little more careful that you do not have gray cell degeneration, right? The clinical work, please keep it up.
Thank you so much, ma'am. Now let's welcome back Dr. Rajan Barokar onto the stage. He will address the topic of managing anticoagulation, sedation, analgesia, and HIT.
मैंने केबल नहीं निकाला, ये है क्या आपको कुछ? ये कुछ है क्या आपका? ये वाला निकाल दो, इसका कोई काम नहीं है इसका। इससे हो जाएगा
ये कॉपी हो गई?
Good morning again. So, having said that ball rolling about the ECMO management, I'm going to speak on anticoagulation in ECMO and a few slides on sedation and analgesics. So ECMO it has a complex treatment modality. All of us know that it is not simple. There are a lot of hemodynamic changes that would occur. There are a lot of drug-drug interactions that can occur, and there's a lot of change in pharmacodynamics and pharmacokinetics that occur while the patient is on ECMO. So there is a pathophysiology of impaired hemostasis when patient is on ECMO. The use of anticoagulants is different. The role of hemostatic adjuncts is also needed sometimes, and that is also different. There are different tastes of anticoagulation that we do when the patients are on ECMO, and then later on we can see the future directions which can be there in anticoagulations. Why there is an impaired hemostasis in ECMO? This is because of exposure of blood to non-biological surfaces of the extracorporeal circuit that activates both the coagulation and inflammatory pathways. There is an ongoing disease process that can cause varying degrees of immune dysregulation, endothelial dysfunction, and of course consumption of coagulation factors. The underlying disease process itself can lead to SIRS. Then there is a widespread cytokine storm that we all are aware of. Complement activation is there, interactions between inflammatory cells and endothelium, which is also there, and that is something which impairs the endothelial integrity. So we have a changes in the platelet functions as well as in coagulation systems. This is complex with whatever foreign body is there in the blood vessel, and here there is a cannula, and there's a lot of activation of platelets by adhesions, aggregations, then activation of intrinsic pathway, activation of extrinsic pathway, and a lot of complexities that involve over there. So if you look at the pathophysiology, as I said, platelet activation, activation of pathways, activation of extrinsic pathway, then there is an acquired von Willebrand syndrome, then there is acquired antithrombin deficiency, and that is something which leads to heparin resistance, and your patient's APDT is not getting optimized. These are all difficulties that we face here. And this leads to again either thrombosis or a coagulation disorders. So ideal anticoagulant that we want to use in patients who are on ECMO should inhibit platelet and coagulation system activation within the ECMO circuit. It should be easily titrated to our clinical expected effect. It still allow endogenous activity, not only anticoagulant at the ECMO circuit, but the coagulation also in the in vivo. And it should be easy to monitor. It shouldn't be a complex monitoring system. It should be easy to antagonize. So if the doses are high, which are the drugs that would reverse that effect of that particular anticoagulant? And lastly, it should be inexpensive. So there are various anticoagulants that are used while patient is in ECMO. The number one is heparin, which is universally used, unfractionated heparin, not low molecular weight heparin. And then there are direct thrombin inhibitors like bivalvuridine, argatroban, and there are regional anticoagulants that is coming into practice. So maybe future will belong to regional anticoagulants that is still in the nascent stage. So we know that heparin acts by activating antithrombin, and it's not a direct thrombin activator. And heparin its anticoagulant effect is basically mediated by its interactions with two endogenous anticoagulants, that is antithrombin and tissue factor pathway inhibitors. Unfractionated heparin has a complex glycosaminoglycan that binds to antithrombin via a pentasaccharide sequence that is only present in few of the unfractionated heparin molecules. And once bound, it has an immediate accelerated inhibitory effect on coagulation factors as compared to antithrombin alone. So when the measured ACT, activated clotting time, that drops to 300 seconds or below, the unfractionated heparin infusion is typically initiated at a particular dose. So there is an algorithm for initiation of heparin while the patients are on ECMO, and these algorithms are to be followed, titrated with 4-hourly ACT levels, and as per the ACT algorithm protocols, wherever you want to maintain it, either 140 to 180 seconds or 160 to 200 seconds, you can titrate the dose of the heparin there. Sometimes there are situations wherein the optimization is not possible in spite of increasing the heparin dose. These are the situations wherein you should suspect antithrombin deficiencies, and therein, in spite of patient being on anticoagulant, you may have to give antithrombin to actually optimize the effect of heparin. We'll not go into the details of this. Coming to monitoring of anticoagulation, there are many options for monitoring heparin anticoagulation. There is no perfect test. ACT is useful, quick, but not that much sensitive. APTT is affected by acute phase reactants that we all know. Then anti-TNA, it also can be done. That is expensive, and same is with a TEG or ROTEM. That is also available, but expensive and some time consuming. The base test is the one which you can use in your own ICU. So maybe ACT and APTT probably are the answers for us to use that in our own ICUs. Anti-TNA activity or TEG monitoring may not always be possible everywhere. This is a chart for monitoring of anticoagulation ECMO. If you want, we can take that chart later. But depending on the test like ACT, APTT, anti-TNA or TEG and ROTEM, each one of them have a pros and cons. We should be aware of their pros and cons while we are monitoring it. The discussion into tests of unfractionated heparin, as it is the most common anticoagulant used for ECMO, they are like, we know that they are ACT, APTT, anti-TNA, TEG-ROTEM, but they are all potential means of monitoring for heparin anticoagulation only. And these are like some details about ACT. We will not go into those details. If you want, you can take this presentation and you can go through it. However, there are few causes of prolonged ACT, and that includes, number one is heparin itself. Number two is hypothermia, hypofibrinogenemia, other clotting factor deficiencies, hemodilution, aproteinin, thrombocytopenia. So we should be aware of these other factors apart from the inactivity of heparin. So it is not always that the heparin resistance is there or the antithrombin deficiency is there. We should rule out other factors for inactivity or prolonged ACT. APTT, similarly, we monitor the levels of the APTT between 60 to 80 seconds for a proper anticoagulation. Anti-TNA activity, it is little expensive. It is not available everywhere. But if you could actually monitor anti-TNA activity, that is probably good. And there are studies which are still in the pipeline which would tell about the actual efficacy of anti-TNA monitoring versus the other monitoring tools. TEG-ROTEM, these are the viscoelastic test of homeostasis. These are also done at some centers, but it is not commonly available or routinely available, so maybe they are beyond the reach of common programs. The general guidelines, naturally we start with the heparin, we monitor ACT, we monitor APTT. ACT to 1.5 times the normal levels, APTT also around 1.5 to 2 times. And there are other measures by which if ACT and APTT is not giving you actual insight, then we can take a use of TEG to see what is exactly happening there. Then there are direct thrombin inhibitors, which are relatively new class of short-acting anticoagulants that bind to active sites on thrombin directly, and they demonstrate more predictable pharmacokinetics and greater reduction of thrombin generation as compared to unfractionated heparin. They are better, definitely, but it still needs further studies to titrate the doses that are required for the direct thrombin inhibitors. These are a few of the thrombin inhibitors that are used in earlier studies like bivalirudin, argatroban. So there are case reports and there are retrospective studies which has somehow guided us to decide about the initiation dose and maintenance dose of bivalirudin and argatroban. Advantages, they bind thrombin directly, they are independent of antithrombin, making them more reliable in patients with low or fluctuating antithrombin activity. They do not bind to other plasma proteins or cells, and as a result are not prone to day-to-day changes in serum chemistry. They have a less bleeding complications compared to unfractionated heparin, making them useful in extracorporeal life supports. They inhibit both clot-bound and circulating thrombin, and they do not cause any immune-mediated thrombocytopenia as happened with the heparin. Disadvantages, it limits the use of direct thrombin inhibitors. It's more into a cardiopulmonary bypass than extracorporeal life support, and it is the lack of a pharmacologic antidote or reversal agent such as protamine that can be used during a heparin overdose. Well, this is details about a bivalirudin. We are using this especially when we are suspecting either resistance to heparin or a contraindication to heparin like heparin-induced thrombocytopenia. then this is a new idea that has come. I mean, is it necessary for that anticoagulant to go into the body and cause anticoagulation everywhere? So probably regional anticoagulation would work better there. The one which is being in studies is nafamostat, and that is in pipeline for a better use. One is nitric oxide releasing circuits that probably will maybe in, there are studies which Dr. Rashmi was quoting, and nitric oxide was used almost in many of them. Hemostatic adjunct I will not touch, as Dr. Belekar is going to talk about it. We had to use future direction probably would be unfractionated heparin versus thrombin inhibitor, reducing the bleeding complications, and better anticoagulation monitoring algorithm. Probably the key lies there. You should have a better algorithms. Sedation, well, there is nothing great about sedation, but whenever patient is on ECMO, sedation is must to relieve that pain and anxiety and to increase the patient comfort and safety. You need not paralyze the patient when they are on ECMO. Even you can do an awake ECMO, you can do an ECMO with mobilizing the patient while being on ECMO. So we wish to reach to that level of ECMO management wherein patient can be mobilized with ECMO and ventilator attached to him, actually making them walk. I think there are protocols for anglo-sedation when the patient is on ECMO. Will not go into the details. And we should know the drug properties of Dexmed, Midas, ketamine, whatever is being used. These are algorithms and the doses. And I stop here, and again, thank you so much for giving this opportunity. Thank you.
Thank you so much, sir. Our next speaker is Dr. Swapna Khanzode. She will be discussing management of ECMO patients, drug challenges, and fluid therapy.
Yes, ma'am.
मैम ट्रबल शूटिंग तुमचा आहे ना
हे माझं याच्यावर उभी राहू
मॅम ॲक्च्युली ते या दिस फोटोजमध्ये येणार नाही त्याच्यामुळे
नको रे उभी राहू सिरियसली
पण तुमचं प्रेझेंटेशन एक ना हेच वाला ना
I think till the time Dr. Sapna is ready with her slides, I would like to acknowledge and express my gratitude for our colleagues and the co-faculties in Nagpur for having extended their support by giving the ECMO machines. So we got a ECMO machine from New Era Hospital, we got a ECMO machine from Criticare from Dr. Deepak Jaiswani's and Dr. Jaiswal's group. So it's so nice of them to provide this, and that has probably strengthened the teamwork amongst us. And my good friend, my mentor, my big brother Nirmal is here, so we welcome him.
Good morning, everyone. At the outset, the heartiest congratulations to KIMS-Kingsway for organizing this wonderful workshop on this exclusive therapy of ECMO. I think it was long due. We were all wanting to do it, but you guys managed to do it. So really great going. So today I'm here to discuss about pharmacotherapy and fluid management in ECMO, which becomes an important part of management of overall patients who are put on ECMO. So ECMO is basically used as a in a goal-directed manner to achieve therapeutic endpoints, which will allow reversal of disease. So when we are putting the patients on ECMO, it is also important that the effective treatment of primary disease and subsequent complications, either prevention of them and otherwise treatment of them, has to be accurate. So pharmacotherapy and fluids are integral part of this supportive management of patients on ECMO. However, since its enable is limited and still certain studies are ongoing. Now, when we talk about pharmacotherapy, what are the issues that we face? One is introduction of ECMO leads to kinetics of drugs. Why? Because there is a lot of drug sequestration by the circuit, there is increased volume of distribution, hence the available therapeutic plasma concentration is not at times achieved, and of course because of multi-organ dysfunction, mainly liver and hepatic involvement, there is altered drug clearance. So this is a little busy slide, but still one can see that critical illness itself can cause augmented cardiac output, leaky capillaries, altered protein binding, and end organ dysfunction, which hampers the PK/PD of the drugs which are used. When you add extracorporeal membrane oxygenation therapy to this, ECMO causes furthermore increased volume of distribution, so less therapeutic plasma concentration of the drug. Why? Because there is adsorption by the tubings, there is systemic inflammation which causes discrepancy and alteration in your albumin concentration, protein concentration, and hemodilution. Why? One, because of the blood products that you give, or the priming solutions, or the per se ECMO circuit volume itself. And yes, decreased clearance is adds to it. So ECMO circuit adds to extracorporeal volume, it causes increased drug adsorption. The sequestration can further be influenced by oxygenator materials, types of conduit tubings, age of the circuit, and even the composition of the priming solution. It's seen that less adsorption is observed in circuits with shorter tubing and by using centrifugal pumps. Here, physicochemical properties of the drug also play an important role. Lipophilic drugs penetrate more into the tissues, hence have lower plasma concentration and high volume of distribution. So these drugs are more prone to sequestration in ECMO circuit. There is something called as octanol water partition coefficient, or commonly called as log P, which actually is a measure of drug lipophilicity and helps us in stratifying these drugs. Higher the log P of a drug, it is more lipophilic and more chances of getting it sequestered in ECMO tubings. Now, when we talk about volume of distribution, we know that it is nothing but the amount of total drug and the amount of plasma concentration that that drug will achieve versus the amount of extravascular concentration that the drug will achieve. Now, the volume of ECMO circuit increases total blood volume. There is hemodilution component because of repeated blood transfusions, fluid administration, and of course the systemic inflammatory response. And decreased drug clearance is largely because of renal and hepatic dysfunction. Hypoxia adds on to it, and also there are alterations in the regional blood flow, per se because of the disease process or because of the introduction of the ECMO circuit. So this is a comparison chart between hydrophilic and lipophilic drug, and wherein you can see that the effect of ECMO on the PKs of both hydrophilic, lipophilic is about increased volume of distribution. However, there is increased clearance of lipophilic, but there is no change in clearance of hydrophilic drugs. So therapeutic drug monitoring becomes more important wherever it is possible in such patients. So ECMO and pharmacokinetics of antimicrobials. Now, as we all know that it is an important aspect in case of ECMO patients using antimicrobials, and there is no real-time feedback as far as these antimicrobial usage is concerned. It is more directed by the laboratory markers. So the physicochemical property of the individual drug has to be taken in account, whether it is lipophilic, hydrophilic, so on and so forth. And here the therapeutic drug monitoring becomes beneficial. So beta-lactams are relatively hydrophilic. The protein binding is variable. More or less, they have low protein binding, except drugs like ceftriaxone, which is more than 85% protein bound and would likely have a higher drug sequestration into the ECMO circuit. However, the studies have shown that dosing can be more or less similar to patients who are critically ill, but not on ECMO. Then coming to piperacillin tazobactam, again there is minimal circuit sequestration. However, there is enlarged volume of distribution. Dosing is same as non-ECMO critically ill patients, and continuous infusion or extended infusion would be better. As it is, we follow this even in critically ill patients who are not on ECMO. Vancomycin has increased volume of distribution, minimal circuit sequestration, and decreased drug clearance. Now, a retrospective PK study showed that conventional intermediate vancomycin dosing would not be enough, would be insufficient, and hence continuous infusion on ECMO would be better. Voriconazole, up to 71% of drug loss happens in circuit, and that is because of this high log P value, and hence initial doses and daily doses required are higher than usual. And here this therapeutic drug monitoring again is advised. Caspofungin dose adjustments may be required, however the data is not still sufficient. Pharmacokinetics of antivirals like oseltamivir does not seem to be significantly influenced during ECMO support. Sir has already touched upon sedatives and analgesics, just few words about them. Ex vivo studies using ECMO circuits and oxygenators have demonstrated that there is significant loss of these drugs due to sequestration. So increased doses of sedatives and analgesics are generally required. So this is a chart which says how much is the drug lost in the sequestration and how much high dosing it is required. Few words, this acetaminophen is significantly less lipophilic and protein bound than fentanyl. Dexmed is highly lipophilic and up to 90% of the drug is lost in an ECMO circuit. This becomes important because when we formulate or when we put a patient on sedation or give analgesia, these points need to be kept in mind. Other drugs like theophylline has increased volume of distribution, longer half-life. Furosemide can be lost in the circuit components, but there seems to be no difference in intermittent or continuous administration. Levetiracetam is hydrophilic, has minimal protein binding, so does not seem to be affected by ECMO circuit at all. However, phenobarbital and phenytoin are highly sequestered in ECMO circuit, hence a higher phenobarbital loading dose and maintenance dose may be required. Amiodarone, highly lipophilic, again higher doses may be required. Hydralazine, no changes, and nicardipine also higher doses due to larger volume of distribution. By and large, one should know whenever a drug is administered to the patient, what are its physicochemical properties and how the pharmacokinetics is going to be altered so as to achieve the desired concentrations. Additional points to remember, IV drugs to be administered directly to the patient and not via ECMO circuit. Clotting factors and lipid-rich solutions should not be given via ECMO circuit as they can block the oxygenator. And therapeutic drug monitoring, again I'm emphasizing, helps to prevent toxicity and monitor the efficacy of whatever drugs we are administering. So that's about drugs. And few words about fluid management. So important thing about fluids is that initial 24 to 48 hours of ECMO, there are abrupt hemodynamic changes, as we all know. There can be vasoplasia leading to hypotension and impaired circuit flow. And of course, the systemic inflammatory response adds to the intravascular volume depletion and capillary leak. It is said and recommended that a gradual increase in ECMO flow can help preventing the above effect. Having said this, we should be prepared that this might happen and anticipate these problems. Now the goal is to ensure adequate vascular volume so that desired gas exchange can occur, and this depends on sufficient blood flow through the oxygenator. Most of the patients after initiation of ECMO, as we all know, require fluid resuscitation. So the standard circulatory goals remain mean arterial pressure of more than 65, cardiac index of more than 2.2 liters per minute per meter square, and monitoring lactates, normal lactate levels are desired. So central venous access invasive BP monitoring are recommended. Echocardiography, no doubt, is the mandatory thing. Now we use it even in all ICU patients for hemodynamic assessment and as a guide to fluid management. With initial fluid resuscitation, we have seen that with the resting ventilatory lung settings, many a times there is aggravation of pulmonary edema when we start initial fluid resuscitation. So the lung compliance decreases and tidal volume falls. But if the systemic oxygen delivery is fine, do not try to increase the tidal volume and try to maintain the resting ventilatory settings as it is. After initial fluid resuscitation, generally after 48 hours, if the renal parameters are good, there is a phase of autodiuresis, which indicates that there is adequate organ perfusion, and it is taken as a good sign. But then, again, the renal parameters should be normal. If they are not, then we have to think, if there is oliguria which is persisting, that we might have to think of diuretics versus renal replacement therapy, depending on the patient's condition. After this initial resuscitative phase, conservative fluid management strategy is followed. That is, negative fluid management is desired. As we know, ARDS patients, even with ECMO, they have found that negative fluid balance is usually better than the positive ones and has helped in improving the outcomes. So initial resuscitative 48 hours, take care of the fluids, but once that initial phase is gone, make sure that the fluids are conserved and more or less negative balance is achieved. So just 2 minutes. Chatter and suck down are two important problems which have to be kept in mind while dealing with fluid dynamics in ECMO patients. I'm sure these will be discussed eventually in the next subsequent lectures. Now comes the type of fluid which should be used for resuscitation. It's largely patient specific, depends on why the patient has been put on ECMO, what is the basic etiopathogenesis. So that will decide which fluid has to be used. So in a nutshell, pharmacotherapy and fluid management are important aspects in managing a patient with ECMO. It is important to know about pharmacokinetic properties of the drug and also the hemodynamic changes that happen during initiation of the ECMO. And the drug and fluid management needs to be individualized depending on the characteristics of the patient and depending on the underlying etiology. So as they say, one size does not fit all. Thank you.
Thank you so much, ma'am. Now presenting Dr. Nirmal Jaiswal, sir, an expert with over 25 years of extensive experience in this field, to shed light on the ventilatory management of ECMO patients.
जास्त वरती नाही झालं कसं करेंगे Yeah, good morning. Thanks, Rajan. Rajan, it was a wonderful, maybe I'll call it as a get-together for a different subtopic of our critical care, right? And thanks for giving me this opportunity. As you said, we are family, so for you anything, right? Thank you. After wonderful deliberation by Swapna, what she said, I start the last slide of yours and then I'll start my lecture. One size doesn't fit it at all. It is the same for, again, ventilator also as well. You know, whenever the patient comes with the ARDS, right? So what the theme comes in the mind as far as the ventilator setting is concerned is there. You just give the little bit ARDS net protocol, what we call it as a low tidal volume and high PEEP. That is basically to prevent the ventilator-induced lung injury. Let's see what happens in ECMO, how we set in the ECMO in that. So we should understand the ECMO as well. I think in previous lectures, previous talks in the mornings, you must have come to know what is ECMO is as such. What is ECMO? ECMO in my language is, it is something like called as when the patient doesn't have the urine output or the kidney failure goes on, so we get the dialysis machine, that what we call it as the artificial kidney for a time being. They are the same. What is ECMO is when the patient is not maintaining the oxygen in that scenario, in spite of your ventilatory strategies, then you are supposed to have what you call it as the ECMO. ECMO is nothing but it blends the oxygen in the blood, which is coming out of the body and goes in the body again, so that there is no question of any oxygen in the body which is been deprived of that particular scenario. So what are the principles of this management? It is definitely an individualized approach. It should be recognized. It's a unique needs of each ECMO patient to tailor the ventilator settings. Lungs, it is definitely, we should plan the strategy in such a way, the lungs should go in a absolutely resting phase, and the ventilation should be synchronized. So these are the patient, what we get is ARDS, that if we do the scans of this patient, if the hemodynamics allows, in that scenario we should get the scan. So these scans are very horrifying. Sometimes before ECMO introduces, we always feel that there is a time has come for this patient to on the negative side. But you know, there are some few papers came. If you just see these scans, for example, even if we tailor-made our own like ventilator strategy for that particular patient, if you see only the green area, like the blue area which is there, this is hyperinflated because of our own ventilatory strategies, where the green is little bit normal, right? Now, there is one concept is called as baby lung. Right, there is a concept is called as baby lung. So whatever the today's talk is nothing but the setting of the ventilator in a patient who has got a ARDS with ECMO. So you should know what are the villi or maybe the that is patient-induced the lung injury. So if you see this baby lung, so what happens, you know, whenever the patient is on a ventilator, so there is always a patient is conscious, for example, the strategy is like let the patient remain conscious so that we will have the more positive effect rather than the paralyzing patient. So if the patient has a dysynchrony, so in that scenario, you definitely get something like distribution in a very haywire way of the tidal volume. There will be the excessive PEEP which causes the over distension of the alveoli, and if there is a, for example, if the insufficient PEEP is there, then the peripherally the alveoli may not distend. So there will be haphazard way of distribution of the whatever the ventilator setting you do in the patient. So that you should keep it in mind. So the strategy should be in such a way, all these disadvantages of the ventilator should be kept in mind while setting the ventilator. So in another muscle, the muscle is the nothing but the diaphragm, which is the very, very important. If you overinflate it, and if this diaphragm causes, it gets the compressed by your overinflation, then definitely there will be the muscle injury also as well. So that is to be kept in mind. So whenever the lung injury is there, the lung injury causes the hypoxemia, it causes the hypercarbia, it causes also the inflammation. So this inflammation, while management of the ECMO, you should keep it in mind, because whenever you overinflate the lung, then definitely there is a release of the cytokines. That is nothing but causes the inflammation, and that thereby again deteriorate the patient. Even in the patient we support with the ECMO as well as the ventilator or whatever the patient came with all this treatment of that particular disease, and this causes the lung edema, right? So one should keep it in mind, ARDS lung should be little bit dry, right? So in that scenario we can avoid the lung edema. If there is a lung edema or maybe the hypoxia persistent, in that scenario what we do, if there is a hypercarbia, that there is a hypoxia, there is always a increased respiratory drive, and there is because the patient has to compensate for that hypoxia. In that scenario, there is always a increased respiratory effort, and thereby it causes again the muscle loss. So if there is an inappropriate stress or strain is there, and if there is a unventilated patient, this dysynchrony leads to the what you call it as the injury to the lung. So that thereby, while managing this ECMO patient, you should keep it in mind. It also causes the lung injury itself. So this lung-related causes villi, right? So that depends on the lung size, how baby the baby lung is. That should keep it in mind. So whenever you just try to adjust the setting of the ventilator, you should as if you are ventilating the baby lung rather than the adult lung. So that we will not get that sort of complications secondary to the ventilator itself or settings itself. The another is the ventilator-related causes the villi is the mechanical power, that whatever we set in that scenario, you should keep it in mind. What is the level of the driving pressure? What is the level of the tidal volume? What is the level of the respiratory rate? How much PEEP you are giving? At the same time, how much flow you are giving? So there is a concept of baby lung which has come out from the Gattitoni as well as the Pesenti. So from the physiological perspective, the baby lung helps to understand the ventilator-induced lung injury. So in this context, what appears dangerous is not the tidal volume per kg, but instead it is a tidal volume for that particular baby lung ratio. So the practical message is, the smaller the baby lung, the greater is the potential for injury secondary to the mechanical ventilation. That is to be kept in mind. So what is the take home? Treat the baby lung very, very gently, because it's, when we just go through this, for example, this scan, we don't have any much lung here, right? We don't have any much lung. It is always studied with infection or the inflammation. Now, these are the X-rays what we get day in, day out in ARDS, or maybe in patients who are having any infection because of the sepsis also as well, or maybe because of the trauma itself. So these are the scenario, white lung totally, along with little bit barotrauma around, right? Then at the same time, the HRCT chest shows there is no lung remain for that to maintain or demand of the oxygen by that particular patient. So what the ECMO is for the ARDS in adult patient, which is very nicely been written by the Daniel and Matthew in NEGM 2011. So he has mentioned what are the principles, because I am taking the little bit ECMO in my talk, because the ECMO and the ventilator goes along hand in hand in that management of the ECMO also as well. So what are the principles of the VV ECMO? Why we put on the ECMO? Basically to replace the pulmonary function. What I said, it is the artificial lung, what we call it as, and to allow the lung to rest. That is the most important. Whenever, like if it's very, very simple example, if you get a fracture in that scenario, all orthopedic surgeons keep that fracture in the plaster or tang dete hai basically, so that it should heal very nicely. So that lung, if it goes in the rest in that scenario, there are chances there will be reduction in the inflammatory markers, and there will be reduction in the inflammation in the lung, and thereby it causes the recovery of that lung parenchyma normally. And another is, and thereby it causes the healing of the lung. That is the basic principle which has been shown by this Daniel and Matthew, and it has really opened our eyes. So this, as far as the mechanical ventilation during ECMO is concerned, which is almost like in 2014, this Smith et al. Has clearly mentioned in our critical care, which is we are regularly following this in our day-to-day practice. What this ventilator causes, one is volutrauma, basically the high tidal volume, or maybe the more high PEEP, because it is all tailor-made teaching what we get. It depends. It is not like that when I said you just maintain around 15 PEEP in any ARDS patient. It is not like in this ECMO patient. It depends how the patient behaves, how the hemodynamics maintains. Thereby, that is called as optimization of the PEEP should be there to avoid this volutrauma. The PEEP should not be less than 10. That is a dictum. The PEEP should not be dictum, because as you know that what I showed in the previous slide, there is always the atelic trauma. That is something like called as the gas is not reaching there, or the pressures are not reaching there that peripherally, and that causes the collapse. Another is barotrauma. There is very dreadful complications, very, very difficult to treat. So that you should adjust the tidal volume to a minimum. Another is biotrauma. The biotrauma, again I said, it is a cytokine surge induced by your own ventilator settings. So it will again add to the cytokine storm because of the sepsis, or maybe the H1N1. Another is myotrauma. The myotrauma is again the muscle loss because of your ventilator strategy. So what is the objective of this ECMO? The objective of the ECMO is oxygenating the body and resting the lung. That is the basic objective of this ECMO. Very beautiful concept. And what should be the objective of the mechanical ventilation for patients ventilator on ECMO is a low pressure, low tidal volume, and preserve the diaphragm activity. That is the most important thing to be kept in mind forever when you are dealing, or maybe you are going from this symposium to your hospital and then the patient is on ECMO. So what is to be kept in mind while setting the ventilator in an ECMO patient to avoid the lung injury? So there are only 3 parameters to keep it in mind. One is tidal volume, another is flow, another is respiratory rate, another is the PEEP. These are the 3 most important things to keep it in mind while adjusting the ventilator setting. So use always high level PEEP. That is the most important thing, because as I said initially, if you keep the low PEEP, it will not justify to prevent the atelectaoma. So this is another good paper, the pumpless extracorporeal lung assist for the protective mechanical ventilation in experimental lung injury. It has been done before coming to the human being. So what the conclusion was? The combined ventilation with low tidal volumes and extracorporeal CO2 removal as compared with the traditional low tidal volume without extracorporeal CO2 removal is not associated with differences in organ injury. That is the bottom line. So obviously the ventilation with tidal volume, what has been set for the ECMO patient is always less than 6 ml per kg, may cause pulmonary de-recruitment when PEEP is not adequately increased. Unfortunately, in this trial, the PEEP was only the constant, that is around 7. That was the drawback of that. If the later on the few papers came, if the PEEP is more than 10, then in that scenario, this problem will not occur. Now, mechanical ventilation management during ECMO for ARDS, a retrospective international multicentric trial. So this is what is there, in initial days, maybe around day 3 or day 4, around the first week, you should have the more PEEP, around say 15 initially to start with. So by the time the lungs goes for the rest, ECMO takes care, and at the same time, you just go on towards the positive aspect of this ECMO. That concept has to wiped off from the mind. ECMO is the dead end. ECMO is not a dead end. ECMO can give the life to the patient. So another very, very important, we talk about the tidal volume, we talk about the respiratory rate, also we talk about the PEEP. But driving pressure is the most important to look into it and monitor the driving pressure. So what is driving pressure is the plateau pressure minus the PEEP. That is the driving pressure. So when we maintain this driving pressure less than say 20 or less than 15, it reduces. How it will reduce? It will, if you reduce the tidal volume, then definitely the driving pressure goes down, and that will also allow, when you reduce the tidal volume, that will allow the increase the PEEP. That is the most important, beautiful aspect of reducing the tidal volume for increasing the PEEP. So this NHGM, it is a very fantastic article which I came to know. There is a driving pressure and the survival in the acute respiratory distress syndrome. So if you see this first, right? So whenever you have the high tidal volume, for example, your driving pressure goes on higher side, right? These are the empty bars are the what you call it as the driving pressure, and the dark bars are the what you call it as the PEEP, right? So if just see this is the lower diagram is for the mortality. So as you have the more driving pressure, the mortality goes on higher side. If on second chart, if you see here, so what is there? They are maintaining that driving pressure to a minimum extent up to the 30. So, but the mortality, if you see, the bar is almost horizontal. So we are achieving something else in a positive direction. That is the most important thing. Now, even the setting of ECMO, definitely like I already spoke to you regarding in the setting of ECMO, there is a chances of getting the driving pressure less than 15 also as well. Just see here in this diagram, the same paper. This is something like called as the driving pressure goes up to 35, which is not been supported by the ECMO. So, if you just attach this ECMO really plays a major role. And the target with the ECMO, if we keep it in less than 15 days, then we really achieve the further problems of this ventilator-associated injury to the lung. So reduce the respiratory rate, because at the same time, what the rate means for, what is the rate is for, respiratory rate for, it maintains the oxygenation or ventilation. But for what? It is for the oxygen. But at the same time, you are giving the 100% oxygen from the ECMO. So at the same time, there is no need of what you call it as the respiratory rate even. Even you can have the apnea ventilation at the same time, right? So always keep the respiratory rate around 10 or less than 10. Reduce the FI to the 0.3 almost. I'll keep it on 0.3 because you are already giving through the ECMO 100% oxygen. So why is spontaneous ventilation is desirable in ECMO? So as you know, like what Rajan has also said, even Dr. Sapna has also said, like there is no sedation, one should not use the paralyzing agent. You should use the, what you call it as the sedation, and I'll keep it around 3 to 4, that scale, so that I can talk with the patient. Patient can listen to me. Patient can have the music also at the same time, so that he will be concentrating on that music rather than what is going on around, right? The same, for this, there is a rapid disuse atrophy of the diaphragm fibers in mechanically ventilated humans. So that's the reason you should preserve the respiratory muscle function by adjusting the ventilator strategy in that particular way. And also improve the VAQ and regional ventilation. It has always been a pressure support or pressure control or the APRV modes to be kept in on this ventilator, so that we can, it has been justified with so many trials now. The CMV is to be avoided. It has to be pressure control to avoid the ventilator-induced lung injury. So control of plateau pressure and the PEEP is the most important thing. The spontaneous breathing permitted, not synchronized with the pressure cycle. The driving pressure determines the tidal volume, not your settings, but at the same time, it allows also the monitoring of the compliance of the improvement in that particular lung and help in ECMO weaning as well. So determining the optimal ventilator setting in a nutshell, one should do the lung assessment first before going for anything by all the imaging techniques, what you have. ECMO cannulation, I would like to add here, because the ECMO and the ventilator goes hand in hand, what I said. You should have the maximum flow rate to remove the what you call the CO2 at the same time, and at the same time, how it will be done by using the large bore cannula. That is the most important. When you want to increase the flow, at the same time, if the diameter of that cannula is lesser, whatever you do, it will not happen. Another is the gas optimization. So common strategies for the adjustment is the incremental adjustment, what I said just now. The mechanical ventilator weaning to be started. It should be stepwise reduction of the ventilator support as the patient lung function improves. And the prone position also has a little bit carrying a lot of weightage in the same time. So what the challenges what we face? Can I take another 3-4 minutes? One is the ventilator lung injury, I already discussed. Air leak always there. If you can have the barotrauma, you can have the pneumothorax in the same time. And the thromboembolic events, what Dr. Rajan has said just now. So monitoring is very important for evaluation and to get the weaning of this ECMO also at the same time along with the ventilator. There are 2 important studies which has come, that is CISAR trials in ECMO group. I request or suggest to you all, go through these trials. They are very wonderful trials. So what should be the strategy for the mechanical ventilation in ECMO patient? One is reduce the tidal volume to the limit of almost not more than 250 ml. This is one. That is almost like 3 to 4 ml per kg of that per kg. That should be the goal. The increase that PEEP more than 10 should not be more than 15. We are not European and we are not what you call it as the American world. Our body surface area is like nearly like Chinese people, most of the people. Reduce the respiratory rate around 10, reduce the plateau pressure, try to reduce the plateau pressure by 30, less than 30, reduce the driving pressure to less than 25. If the ECMO is there, definitely we have the less than 15. The proning definitely helps. I don't have to go in the detail because whenever you do the proning, it improves the oxygen temporarily. It has been proved, it doesn't changes the mortality, but definitely it reduces the morbidity. The conclusion is the comprehensive understanding of these ECMOs and the ventilator is very, very important because both are important during that particular time. Thank you for your kind attention. Thank you.
May now I request Dr. Anand Singh Rajput to please give a token of gratitude to Nirmal Jaiswal, sir. Sir, please. Afzal sir, may I request Dr. Afzal Sheikh to share a token of gratitude to Swapna Khanzode madam.
So now, I would like to invite Dr. Prabhat Datta sir on stage to enlighten us on troubleshooting, that is recirculation, chattering, oxygenator failure, pump failure, power failure, etc. and ECMO.
Good afternoon. Thank you, Rajan, for the invitation. This is my first time I'm coming to the Nagpur. So I'm from the KIMS Hospital. I worked in the KIMS Heart Lung Transplant Unit. Today's overview of the topic. Actually, Dr. Rajan told me talked about the recirculation, chattering, oxygenator failure, pump and power failure. With that, I added one thing, LV unloading in case of peripheral VA ECMO. See, with our experience of nearly 500 transplant, I can tell you, if you put a peripheral VA ECMO and you don't answer this LV unloading for 6 to 8 hours, your patient not going to make it. So I'll keep it more practical, these presentations. So you see the also complications, most complications are usually oxygenator failure around 18 to 14% depend upon your respiratory or cardiac in case of adult, followed by your circuit clot, usually that is the thing, depends on circuit and your flow. And lastly, the causes of hypoxia in VV ECMO. See, VV ECMO push for either hypoxia or hypercarbia. So there are two factors which can come. It is a demand and supply difference, either patient factor or mechanical factor. Today I'm going to talk about the mechanical factor like recirculation, oxygenator failure, pump failure, and the power failure. So what is recirculation? It is basically it's become two parallel circuits from the ECMO. From inlet cannula, oxygenated blood is coming back to the outlet cannula to the ECMO. So it becomes two parallel circuits. The flow usually, our idea is to give this flow through the RA to the systemic circulation, it fails. So by definition, it is a condition in which reinfused oxygenated blood is withdrawn by the drainage cannula without passing through the systemic circulation. So how you diagnose? Usually when that desaturation is there for the patient on VV ECMO, then that is one of the causes recirculation. Then color difference, I'll show the one photos, then the calculation. Recirculation should be calculated. These are calculation formula. Normally in VV ECMO around 25 to 30%, less than 25% recirculation is always there. So you don't bother about it. If it is more than that, that time you should address it. So what are the causes of recirculation? One is cannula migration, where both tip of the cannulas are very near. So from the inlet cannula to outlet cannula is coming very fast. Second is excessive flow rates. When the flow rate is more, the suction also will be more because pump is driven by the flow rate. So if the two are nearer, our blood is always goes to the less dependent part and less powerful place. So they will go to the inlet cannula to the outlet cannula. Thirdly, increased resistance in the thoracic cavity. See, it's a natural phenomena for everything. If resistance is there, we try to avoid it, like whether it's blood or fluid. So if there is any intrathoracic pressure is more, blood from the right RA cannula, it usually don't go to the cross the tricuspid valve to the PA, to the systemic circulation. You try to prefer to come to the IVC, and from there your suction catheter is already there. Through the drainage canal it come. So these three are the main cause of the recirculation. So you can see this X-ray, both cannulas are very near. So usually keep the cannula distance around 8 to 10. So whenever you need duties, you should see both the color difference marking. It should, if both looks very red, so that means recirculation is more. So every duty, it should be progressive. Every duty person or usually perfusionist in our duty, they have a checklist to seek this, to prevent the recirculation. This is the first sign of the recirculation. So management of the recirculation, evaluate the cannula position with chest X-ray. Chest X-ray you can see once. Then if you want to change the cannula position, it is always preferred to do that through TE because that is a real time it will guide you. Especially the IVC cannula, if you want to reposition, T is the best guide compared to the others. Fluoroscopy, getting in ICU, fluoroscopy is not possible most of the time. Avoid excessive palm fluid. I'll get the algorithm there, I'll explain about it. Keep the distance which are 8 to 10 centimeters. Some books says around 12 to 15 also, but on an average, which our experience is 8 to 10 is quite good enough. Avoid higher pressure in the thoracic cavity. So X-ray will tell you if there is a tension pneumothorax, pericardial tamponade or large pneumothorax. In that case, I have to drain it, either put a pigtail or put a chest tubes. And if the lobar collapse is there, put a bronchoscopy. If there is a collapse, mucus plaque is there, you remove that one, so it will improve. If all fails, then you don't have any other option, you have to put an extra cannula. So this algorithm, if the patient is hypoxic, you rule out the patient cause, then calculate the recirculation. If it's more than 25%, initially decrease the ECMO flow. If it improves, fine. If don't improve, you can reposition the cannula, put the TE, see how the cannula resistance. Slowly we do it 1 centimeter, 1 centimeter, see the flow and saturation improves or not. If it is not there, then add a cannula. In case of recirculation less than 25%, you look for the pressure. If the patient is hypovolemic, you think CVP is low, IVC, ultrasound is less than 2 centimeter, give some volume, it improves it good. If it is not there, then you see the pressure across the membrane. If it is not good, that means delta pressure, we call it delta pressure. If it is high, depend upon which oxygenator you're using, in that case you have to change the oxygenator. See, this is the thing, if your ICU it is this thing, this is nothing but called chattering. By definition, it causes rhythmic pulsation of the ECMO tubing due to the erratic non-laminar blood flow. What is pathophysiology? Because the drainage cavity suction is higher than the venous load, it leads to collapse and obstructing the drainage port, causing interrupted blood flow and lead tubing to start chatter. Basically, if you have a plastic bottle, if you put a straw and start sucking, later part plastic bottle will collapse because there is no volume inside. So chattering, that is the basic pathophysiology of chattering. So chattering, if you see the ECMO flow, RPM is high, but your flow is low. And you can see the collapse of the venous cannula. This is not good. If it happens for a long time, patient hemolysis will cause, and your oxygenator can get, and patient, obviously patient will be hypoxic. So causes hypovolemia, vasodilatation, inflow obstruction, sometimes can happen, clots are there, or it touched the wall, sometimes you put a smaller cannula. Increase intraabdominal pressure and it's complex. Just now Rakesh told where you should keep the pressure with the compression will be less. And post-cannula syndrome. Sometimes you put a post-cannula when the blood comes out from the circuit and it's touched the artificial circuit, system for response comes. So that leads to vasodilation and that leads to hypovolemia. Basic pathophysiology is that. So initial that part, better you give the volume and get the patient, it usually improves. So complication, hypoxia is the basic one. Then cell damage and hemolysis can occur. And these hemolysis in turn can lead to the oxygenator failure. Small air bubbles can occur because if you do the cavitation, you call cavitation, small air bubbles in the chatter. And if it is lot of time, it can suck, if you don't reduce the flow and there is hypovolemia is there, ultimately there can be air embolism and can be flow cessation. So management monitoring the pressure in the venous cannula, visual observation of the cannula every day. Identify the cause. Look for the tube obstruction. Kinking is the most common cause of it. Our patient is coughing. Sometimes his neck cannula got bent. That is very common. Volume loss, one of the cause. So look for the bleeding. Sometimes cannula site keep on oozing after doing insertion. Reduce the pump speed. Fluid bolus. Usually, about the fluid, just now madam talked about the fluid. Usually in our setup, we use keep the hematocrit around 24 plus and 5% low sodium albumin we give until I give the albumin level around 3.5. So that usually maintain your oncotic pressure, doesn't allow initial phase of SIRS induced third spacing. And if it all fails, additional cannula you have to put. Oxygenator failure incidence in 12 to 15%. It was the air clots, embolism, plasma leak, and condensation of the membrane. Usually in the oxygenator, we give the oxygen flow from the free, from the side tubes. So when it comes and temperature drops, they make a condensation and they put a layer of air in front of the oxygenator. So that prevents the oxygen perfusion of the blood flow. So, but blood flow. So that is the one thing, but it is every day if you monitor, you can easily handle it. So these are the clots in the oxygenator. This is called a flashlight test. Usually do it to find out there is clots is there oxygenator or not. You take dark the room, take a flashlight, put obliquely to the oxygenator. Every day after few, when you can check it, and there's a clot, black spots will come. So you know, and every day check it how much it's going on. Usually 1 or 2 will be there after 4 or 5 days. So after that usually go on increasing, and in that case you have to increase your anticoagulation or your flow. So oxygenator failure diagnosis, pre and post membrane oxygenation, usually post membrane, and delta pressure. Delta pressure depends upon which oxygenator is using. Like PLS if you use, it is around 25, below 25. Other oxygenator you should have it, usually it will be written on the circuit side. And LDH and plasma free hemoglobin, you can daily see any hemolysis there, it will tell you. But plasma free hemoglobin don't come so easily in our setup, so usually ourselves we follow the LDH. Management regular monitoring of the post membrane and delta pressure. I think Rakesh has shows you the chart. That chart every day should be fill, and evening and morning anesthetists or intensivists should check it everything is proper or not. Increase the, if there is a condensation, you can do this. Increase the gas flow for few seconds, usually it disappears, and you can do it every day basis. And after all, if all fails, you change the oxygenator. Pump failure, pump failure, dislodgement or the fulminant hepatitis, air embolism, massive air embolism, or others are electric failure, say electric motor failure or battery failure. Power switch off. I can give you one example. One day evening I was giving round around 7 o'clock. My staff came, sir, pump is not running. What happened? We started the pump and it was battery backup. It was running on the battery. Behind switch, they forgot to start. So as an intensivist, it is your duty and put a checklist that is pump switch is on or not. It is easy because pump has a light actually, if a switch is on or not. Pump head clots, different pump head clots are there. You remove this one, so we can show you that. See, this is the video of oxygenator change. I think you need a teamwork for this. Take another oxygen set and setup and deprime with the usually you get albumin and blood and keep it ready. Sorry. Achha. Sorry, it was not working. I think it's a quite big video. I think later on in the, you can see this one. I don't want to waste time for it. Only thing I just wanted to show you, if it's possible here. No, it don't. See, it is simultaneously they'll change the neck cannula plus groin cannula. It is a VV ECMO. You see the saturations usually goes down up to 17, so you should be careful about it, keep the effect of 100%. But once you start it, it comes simultaneously within few minutes. So, which I just talked, change the pump. It is a teamwork. DER meticulously, proper size tubing should be there. Monitor the patient. Keep emergency drugs ready. In case of VV ECMO, you'll have problem with saturation and bradycardia. In case of VV ECMO, patient will get arrested also. So keep inotrops ready for that. This is power failure. This is our perfusionist. See, KIMS, we have nearly more than 100 patients airlifted. This is the air ambulance, a shifting patient from, I think, Nagpur, North India. Power backup was not there. So hand crank he is doing. And when you do the hand crank, two things you should always see: the VV ECMO, heart rate, the bradycardia, and the saturation in the monitor. So when you should not do hand crank. If it is air and clots are there, please don't do a hand crank because it will cause more. If it will go to brain and patient, maybe every organ will be good, but patient, especially the VV ECMO, patient will be brain dead. If you have power failure or technical failure, you can do the hand cranking. So this is a chart you can feel this. So this is the thing which I just spoke about, the VA ECMO peripheral. We put a VA ECMO for the cardiac arrest, emergency cardiac arrest. You see the PA pressure and LVDB is quite high in this patient. So you have to offload this heart, otherwise this heart will never recover. So these are the grading for the offloading: mild, moderate and severe. Factors, all the parameters, the arterial blood pulsatility, mixed venous saturation, CVP, echo-wise, pulmonary capillary pressure if you have PA catheter, and the congestion of the X-ray. So in case of mild, you can do the non-invasive unloading. That is, reduce the ECMO flow, allow the LV to contract. If LV contracted is around more than 25%. Followed by, you can increase little PEEP so that venous return goes down. And thirdly, you can dilute the patient. That works well. In case of moderate set, you have to put IABP. That works because you know IABP improves the forward flow due to the deflation of the blood. If all fails, then you have to go invasive cannula. Either you can go to impella, or you have to go to open the chest, or you can put a left superior pulmonary vein cannulation. So mainly occurs 2 to 12 hours post start of peripheral VA ECMO. Usually when the ECPR, this is one of the commonest problems will come. Goal, it should be focused on LV unloading, monitor, which just I told, our CVP, PA, BP waveform, mixed venous saturation. Echo in this, you see the aortic valve is opening or not. In case of severe LV dilation, aortic valve will never open. LV will be hugely dilated and IVC size will be big, more than 2.5 to 3. So techniques, indirect, put IVP or impella. If you are doing cath lab, this patient, you know this stenting problem, impella is okay, but it's costing around 17-18 lakh rupees for 7 days. Protective cannula, you can put it. Rarely you can available, if you have a transplant, you have that. So you drain the patient, you put just now I think Rakesh has showed that photos. Directly you can put the pulmonary vein cannula, left superior pulmonary vein, or put a cannula to the LV axis. But in that case, you have to open the chest. Your surgeons have to be very comfortable because they have to handle this because our patient is already on heparin. So otherwise you can put a right axillary cannula. It helps you both the way. It improves the circulations. But only thing, due to the differential flow, your right hand will get hyperemic and it gets little dilated. So you have to manage that part. Lot of swelling, you can little elevate and take care of that part. But it will LV definitely recover and visually keep this patient this way. This is usually our latest protocol. This is those who want to start the unit. Just follow these three pressures: P pump and oxygenator between P2 and post-oxygen membrane. These three pressure, if you follow with the delta pressures and the flow, you solve most of the problems. So I'm not going to talk about it. Anybody wants, they can keep it as a Perfusionists or intensivists. They know whether it is hypovolemia or pump failure, oxygen failure, or increased afterload or patient-related issues. So if you postulate these four things, it is easy to diagnose and easily you can handle it properly. So in conclusion, timely initiation, vigilant monitoring and watching the trend, proper knowledge, quick corrective measures. One thing I have to tell you, if you really want to write a successful ECMO unit, it is 24/7 job. You cannot expect that my senior will come that time. All seniors has to come on time, anytime, night 1 o'clock, 2 o'clock, anything. So that has to be 24/7. You cannot have 9 to 5 job for ECMO circuit to run. And what Madam told just now, this is always a teamwork. This is our KIMS, Dr. Sandeep Pathak, Dr. Vijil, myself. It is our KIMS Heart Lung Transplant Unit team. Thank you for your patient lessons.
Thank you so much, sir. Now let's welcome our next speaker, Dr. Virendra Belekar, who will enlighten us on the role of 4-factor PCC in management of bleeding in ECMO.
Good afternoon, everybody. After elaborative talks on ECMO, let's have some discussion on the core ICU topic, which we deal regularly, which is more common in ECMO patients too. My topic was 4-factor PCC, that is prothrombin complex concentrate. But I could not find too much of data on this in ECMO. So I thought maybe we'll discuss management of bleeding in ECMO patients with a brief remark on 4-factor PCC. So these will be my objectives. Bleeding in ECMO patients, causes, monitoring, how do we monitor it, viscoelastic testing, management of bleeding, and role of 4-factor PCC. Okay. So managing anticoagulation in ECMO patient is a tightrope walk. As we all know, these patients are more prone for thrombosis, which requires anticoagulation. And due to inherent risk of bleeding in these patients because of development of acquired von Willebrand syndrome, platelet destruction, and coagulation factor deficiencies, these need to be monitored on very frequent intervals. Now, what is the significance of bleeding in these patients? These patients bleed at a rate of around 20 to 40%. Every third patient who is on ECMO will receive at least one blood transfusion during the course of ECMO, ranging from cannula site bleeding, which can be taken care of, but these patients may also develop significant life-threatening bleedings in CNS, lungs, GI bleeds, which require rapid control and good blood bank backup. Coming to mechanism of bleeding in ECMO patients, these patients have the large bore cannulas through which large amount of blood is being pumped out by a centrifugal pump. So they are at high risk of developing acquired coagulopathy due to shear stress that is generated by this centrifugal pump, which leads to the development of what is called as acquired Vaughan Willebrand syndrome. We all know what is the role of Vaughan Willebrand syndrome in coagulation system. We'll see in next slide. This also leads to platelet destruction and consumption, leading to thrombocytopenia. With inherent risk of these patients bleeding due to sepsis and other coagulopathies because of anticoagulation that they are receiving, which develops into heparin-induced thrombocytopenias, and other risk of bleeding in these patients, such as DIC. So in short about acquired Vaughan Willebrand syndrome, Vaughan Willebrand factor is one of the largest polymer that is present in the blood. So this normally what happens, this gets cleaved into monomer whenever there is an endothelial injury, which attracts the platelet, and then further platelet activation and aggregation occurs, leading to activation of other prothrombotic factors like thromboxane, prostacyclin, fibrinogen, and then the secondary hemostasis. These polymers are degraded due to shear stress induced by high flow generated by the pump. So low Vaughan Willebrand activity by Vaughan Willebrand antigen that is present in these patients to less than 50% causes prevents platelet aggregation and inactivation. So this leads to inactivation of ineffective coagulation. The idea to monitor these patients is to treat before they bleed. So this is the protocol that is being followed by medical university. I found this in one of the publication. They follow this in Medical University of Freiburg in Germany. Apart from ACT that we follow in these patients who are on heparin anticoagulation and keep a target of around 160 to 180 seconds, they monitor hemoglobin at an early basis, keeping a target of more than 10%, and transfuse to keep that target to more than 10%. Daily monitoring of platelet, INR and APDT to a target of more than 1 lakh, INR target of less than 1.3 and APDT of less than 40 seconds. And they transfuse platelet concentrates, fresh frozen plasmas, and factor VIII concentrate. So in this case, here in place of fresh frozen plasma, we can use factor IV concentrates, where we require sure shot anticoagulation, coagulation activity, like in patients with IC bleed, where we require rapid reversal of these agents. In these cases, we can use 4-factor PCC. Bi-weekly basis, they monitor factors 8 activity to maintain it at more than 70%. If they find it less than 70%, they infuse them with factor VIII concentrates. And if they say they see clinical signs of bleeding, then they even monitor factor 13 activity and Vaughan Willebrand factor activity, and they keep it at around more than 0.7%. To maintain it in a target range, they transfuse the patients with factor 13 concentrates and desmopressin, which we all know it activates the endothelium and the platelets to release the Vaughan Willebrand factor and increase the activity. In short, about 4-factor PCC, I think this is the only commercially available agent that is present in the market, that it comes with Kcentra. PCC, what is that? It is derived from the fresh frozen plasma. This pathogen reduced lyophilized concentrate of vitamin K dependent coagulation factors, which contains factor 2, factor 7, factor 9 and 10, along with protein C and protein S. 3-factor PCC doesn't contain factor 7. That is the only difference. Indications and doses, its main indication is in vitamin K antagonist reversal, the patient presenting with major bleeding in these cases. So the doses vary according to the INR that we see. If it is more than 6, we can administer along with vitamin K at a dose of 50 units per kg body weight, not to be exceeded 5,000 units, and accordingly 25 to 35 units per kg in cases of 2 to 4 INR, 2 to 6 INR. The factor, the potency is defined by factor 9 activity in this PCC, and repeat or subsequent dosing is not indicated, though in few cases of IC bleeding, you can repeat it after 2 to 4 hours to prevent rebleeding. Reversal of direct oral anticoagulants if they present with bleed, and if no other antidote is available for that oral anticoagulant, and refractive bleeding in cardiac surgeries. So it has been majorly studied in patients with trauma, patients who present with vitamin K antagonist bleeding, and in cardiac surgeries patients. Administration, it is to be administered intravenously, not with a rate of around 3 units per kg per minute to a maximum dose of 210 units. Blood, you should take care that the blood should not enter into the syringe because it causes fibrin clot formation, and then the drug has to be has to be thrown away because that will not be any use. Visual inspection of the reconstituted syringe to see particulate matter and discoloration prior to administration using aseptic technique and at room temperature. Contraindications are the anaphylactic reactions to these factors, disseminated intravascular coagulation, and known heparin-induced thrombocytopenia. Warnings include the patients and the relatives should be warned about the thromboembolic risk complication associated with it, including MI, arterial thrombosis, and venous thromboembolism. Now, how does it differ from FFP? It rapidly corrects INR within 15 to 30 minutes. So it's very good and advantageous in patients who present with IC bleed. Rapidly available and administrable. It can be diluted in 100 to 200 ml of saline and can be administered rapidly. Less risk of volume overload, whereas we know if we want to correct the similar amount of INR in case of FFP, we need to administer 10 ml per kg of FFP. So less risk of volume overload with PCC, less risk of transfusion-related lung injury, less risk of viral transfusion and leukocyte-free, hence it is infusion-related, hence less infusion-related reactions as compared to FFP. The only issue is cost, because I think the one therapy costs around 1 lakh to 1.2 lakhs. So has to be used very cautiously. Now, what to do if your patient starts to bleed, even if he's monitored? So, first line therapy will be to reduce and optimize the dose of heparin. Give tranexamic acid in a dose of 500 milligrams thrice a day. If patient continues to bleed, then substitute platelet and ensure clot firmness with maintaining platelet concentration of more than 1 lakh. Fibrinogen levels of 300 to 400 milligram per deciliter, and factor 13 activity to more than 50%. If patient continues to bleed still, then you have to treat acquired von Willebrand syndrome with either desmopressin or factor 8 von Willebrand factor concentrate. If patient continues to bleed still on this, then you have to go for viscoelastic testing. You have to weigh the risk of continuing ECMO versus bleeding patient. So if patient can be decannulated or shifted on some other therapy, you can think of that. Consider membrane and pump exchange, and we can use recombinant factor 8 active concentrates in these patients. Now, in brief about viscoelastic testing, it is an objective visual representation of blood clotting and fibrinogen. This is a typical rotem that we get in the pictorial representation. The initial red line is indicative of clotting time. Then once the clot starts to form, till the 2 mm of thickness, it is clot formation time, that is CFT. Then we get an A10, that is the clot firmness at 10 minutes, and MCF, that is maximum clot firmness that we see, and then the fibrinolysis starts, where we get maximum lysis. So we monitor it at 30 minutes and 60 minutes. So what the TEG and ROTEM differs in this, where we can derive various inferences by adding few substances in them. So you get 5 ROTEM tests in routinely. INTEM is similar to APDT. It uses phospholipid and it monitors the intrinsic pathway. The HEPTEM is similar to INTEM, excludes the effect of heparin. So here you can monitor the effect of heparin in case if patient is on heparin and you have reversed it with protamine, you can see the residual effect of heparin with HEPTEM. EXTEM is similar to prothrombin time or extrinsic pathway, and EPTEM excludes fibrinolysis. So here you can see whether the patient is under fibrinolytic activity or not, and whether patient will be benefited with antifibrinolytic agents. FIPTEM isolates fibrinogen function. So it, by adding a platelet inhibitor, it observes the contribution of only the fibrinogen for clot formation. So we'll see graphic. So these are reference values for ROTEM. This is the normal study. You can see the normal clot formation time, clotting time. The maximum clot firmness is also normal, and FIPTEM is also normal with MCF of 10 millimeters. Increased clot formation time, decrease in MCF, that is maximum clot firmness in EXTEM, INTEM and EPTEM. But there is normal MCF in FIPTEM. Can anyone guess it? What is it? So thrombocytopenia, because the maximum clot firmness that is seen in FIPTEM, if you can see, it is 16 millimeters. So that indicates that the maximum clot firmness that is seen in all other 3, EXTEM, INTEM and EPTEM, is due to thrombocytopenia. Increased clotting time, clot firmness time, and decrease maximum clot firmness in all other things, except if you can see, MCF in FIPTEM is less than 3 mm. So what does that? This is a low fibrinogen level. In previous slide, we saw that MCF in that slide was more than 15 mm. So that was low platelet. Due to low platelet, it is due to low fibrinogen. Now here, EXTEM, INTEM and HEPTEM are normal. Only thing is, FIPTEM is, so normal CT, so no, sorry. In INTEM, if you can see, the clotting time has increased with normal CT in HEPTEM. So that indicates heparin effect, because once you add heparinase enzyme in HEPTEM, the clotting time, the heparin that is present is negated and you get a normal clotting time. So that indicates heparin effect. A rapid decline of all the amplitudes except in EPTEM. So fibrinolysis, as you can see, all other amplitudes are same. Only the fibrinolytic part, the fibrinolysis part is augmented. So this is fibrinolysis, which the patients can be given fibrinolytic agent, antifibrinolytic agents like tranexamic acid. So this is in short, if you can mug up with this. So this is brandy sniffer, if you can see in these glasses. So it's in a normal ROTEM. Wine glass, if you can see prolonged clotting time, it indicates the factor deficiencies, with patient can be benefited with FFP. Champagne fluid, fibrinogen deficiency, and the inverted martini glass, you can see normal amplitudes with MCF and rapid decline in clot lysis, that is fibrinolysis, patients can be given tranexamic acid in this. So in short, to recap, these patients are at high risk of bleeding as well as thrombosis. We know the etiologies of bleeding, so we keep them monitoring on the lab parameters like prothrombin time, ROTEM. Also, we have got ROTEM, and accordingly we manage them with platelets, cryoprecipitates, von Willebrand factor, and antifibrinolytic activities. So in these cases, if you have limitation with plasma, if patient is volume overloaded, having lung injury or poor lung functions, in that case you can use 4-factor PCC. So I would like to take this opportunity to welcome you all for next year ECMOCon also, which will be held in December 2024. Thank you.
Thank you so much, sir. Let's invite Dr. Afzal Sheikh, sir, to the stage to impart his insights on weaning, trail-off, and decannulation.
Good afternoon, everyone. After lots of initiation, troubleshooting, and maintaining ECMO, monitoring ECMO, now we are moving ahead with weaning, trial off, and decannulation of ECMO. So, how you are going to do it? The objectives of these lectures are what do you understand by weaning trial and what do you understand by trial off? What are the criteria for doing all these things? And if those criteria are met, how you are going to move ahead with this? So what are the protocols? And eventually to decannulation. So what do you understand by weaning? We have done already weaning in mechanical ventilation patients. So there are certain parameters which we control and eventually we lower down the support and make patient independent for breathing himself. Similarly, on ECMO, we control certain parameters that we want to decrease, and eventually the responsibility of maintaining ventilation lies with patient. So with ECMO, you have 3 parameters that is in control. One is FiO2, one is blood flow, and other is sweep gas. So decreasing any of these things over a period of hours or days in an effort to take away mechanical heart or lung support from the patient. That is called weaning. What do you understand by trial off? So trial off means you are stopping ECMO without detaching the machine or removing the cannula. The machine is just attached and non-functional. That means trial off. And removing cannula is decannulation. So what are the criteria when you think about weaning in a patient? First, foremost is if your patient is showing signs of recovery of underlying disease, then you think, okay, now my patient does not require ECMO and I would like to wean my patient. Other possibility could be there might be the situation when you want to discontinue the ECMO support for certain reasons. And there might be situation where there is situation you don't want to continue ECMO further and you want to rushly wean. So indicators of recovery of underlying disease is the foremost parameter. Similar to any mechanical ventilation or any life support, your primary disease has been recovered. So optimum goal for weaning and trial off is, there is in case of ECMO, your pulmonary functions have recovered and your patient is weaned to a minimal ventilatory support. And in case of arterial ECMO, your cardiac recovery is done and your patient is on minimal or no inotropic support. So what are the signs of lung recovery? These are the common basic signs of lung recovery: rise in partial pressure of oxygen, decline in carbon dioxide levels, rising SVO2, improving compliance on mechanical ventilation. Chest radiograph may or may not improve, but there must be serial changes in chest radiograph. and resolution of pulmonary artery hypertension on 2D echo. And there is rise in end tidal CO2. What are the signs of cardiac recovery? Rising SpO2 is one important parameter. Most important factor in cardiac recovery is there is a pulse contour on arterial line. VA ECMO is a non-pulsatile flow. You might see a flat line of arterial pressure. As soon as there is improving cardiac contractility, you will see a trace. So whenever this trace is available, your cardiac contractility is improving. And on 2D echo, you have visible improvement in contractility of heart. There might be situation when you want to discontinue ECMO support. Suppose you have started a patient on ECMO and eventually during run of ECMO, you came to know that patient has certain diseases that disqualify patient from ECMO, like severe and untreatable congenital heart disease, severe chromosomal anomaly, or brain dead situation. There might be some life-threatening condition associated during ECMO, like severe pulmonary fibrosis, so there is no weaning possible, misaligned pulmonary vessels, or severe bronchopulmonary dysplasia. Patient might have been diagnosed with other life-threatening situations like intracranial hemorrhage or cerebral infarction or DIC, which may be exacerbated by the continued usage of ECMO. So these are the situations when you would like to discontinue ECMO and continue on your conventional support. There might be some desperate situations where you want to rushly wean, fastly wean the patient despite non-optimal recovery of the patient. So one important situation is bleeding. Whenever patient is having severe uncontrollable bleeding like intraventricular bleeding, GI bleed or nasal bleed, which is a life-threatening situation, and continuing ECMO might threaten that situation to worsen. So in that situation, you wean that patient off. Severe hemolysis is also another situation. So let's move on to specific type of ECMOs and how you wean it. Let's start with VV ECMO. What literature says about weaning in VV ECMO is there is no optimal or clear guidelines or no optimal approach for weaning patients on VV ECMO to mechanical ventilation, mainly because of limited data. You might achieve three possibilities during weaning on VV ECMO. Either you may be able to wean the patient on mechanical ventilation, that is with good lung recovery, or if there is no lung recovery, you wean for lung transplantation, or if there is non-salvageable patient, you wean as if a patient is on end-of-life care support. So how do you wean patient on ECMO? There are 4 steps. If you achieve these steps, you can wean your patient. So first step is assessment for readiness of weaning. Second step is how your ventilation is being managed during weaning. Eventually, we'll do a weaning test. If that is successful, you will move ahead with decannulation process. So how would you do assessment for readiness for weaning? You have started a patient on ECMO. Few days have been passed. Your pump flow was on 4 liters. Your sweep gas was on 4 liters. Next day morning, you came for rounds. You had your coffee. Resident showed you ABG. Now that ABG is having very good PO2, more than 150, PCO2 is under 45. There is no respiratory acidosis, obviously. Your patient was on either pressure control or pressure support ventilation. Earlier, tidal volume was low. You have seen your tidal volumes are rising up to 6 ml per kg. And with plateau pressures under 25, you saw the monitor, blood pressure is good, heart rate is stable, no arrhythmias. You asked for X-ray. X-ray may or may not improve, but all these parameters are suggesting your patient is ready for weaning. You may think about weaning steps. So now you have to plan how your ventilation is going to be managed during weaning process. Now the work has been done by ECMO, that is being shifted to mechanical ventilation. So what ventilatory settings you will offer is any conventional ventilator settings which we do in any ARDS patient, like tidal volume 6 to 8 ml per kg with peak pressures under 30, with P-plat under 25, and driving pressure less than 15. PEEP requirement should be less than 10, and your blood gas parameters should have good oxygenation, PaO2 of 60 to 65, PCO2 50 to 55, and pH ranges within normal limit from 7.3 to 7.5. And your end organ perfusion should be good. your lactates should be under control. So now you have to move on to ventilatory support and wean off ECMO. If your patient is on CMV controlled mode, then you have to change your tidal volume and PEEP values and FiO2 values to a level when there is a patient can be maintained without ECMO. And on spontaneously breathing patients, you need to adjust your PEEP and pressure support to a level as if patient is being managed on off ECMO levels. During pressure support ventilation, you need to minimize your sedations. So how you proceed for weaning test? So you control 3 parameters: blood flow, sweep gas, and FiO2. So you can reduce FiO2 as well. So you can reduce FiO2 and you can reduce blood flow. That is the major parameter for weaning. You gradually reduce blood flow to 1.5 liter to 1.8 liters and comparably decrease the sweep gas to 1.5 and eventually to 0. What will happen if you do a sweep gas to 0? ECMO is off. So there is no gas exchange in ECMO. So if you can also clamp the O2 supply to the blender. So now if that is successful, your patient is stable, you can now increase the ECMO blood flow to more than 3 liter per minute. Why we are doing this? It is just to prevent clotting in the circuits. So how long you should do it? Like you give a spontaneous breathing trial in mechanical ventilation for 30 minutes to 120 minutes. So there is no fixed duration in ECMO. Usually it is done for 4 to 24 hours. So when you will consider to stop ECMO, you have done everything, you are weaning your patient, you are monitoring your patient. Now your ECMO settings are pump flow of 3 liters, sweep gas less than 1 or 0 with FiO2 minimal. Your ventilation targets are P-flat under 25, patient is able to generate more than 6 to 7 ml per kg tidal volume, and PEEP requirement is less than 10. And with these settings, you are able to achieve PaO2 of more than 100 and PCO2 is under 50. Then you can think about stopping ECMO. There are certain parameters you need to monitor during weaning. First foremost is hemodynamic stability. Any arrhythmias, any drop in blood pressure, you go back on your control settings. Routine hemodynamic parameters, echo evaluation mainly for LV contractility and PA pressures, lactates and pH. On ABG, adequacy of gas exchange is a must. During weaning, you must also monitor the patient, how my patient is breathing on spontaneous breathing or only mechanical ventilation. Is my patient using accessory muscles? And how are the pressures during mechanical ventilation? Sedation strategy during weaning is preferably a lighter sedation is preferred because the procedure needs to be, might be painful to patient. So some sedation, but minimal lighter sedation to preserve the spontaneous breathing. Preferably we avoid benzodiazepines and definitely no to paralysis. A wonderful drug, dexmedetomidine, can be used for sedation if hemodynamics allow. So if all these things, patient is weanable, there is no hemodynamic alteration, no oxygenation problem, you can move ahead with decannulation. How you do it? Your gas flow is 0, your blood flow is more than 3 liters. By evening you have done these settings and you have run it overnight. And again, next day morning, you have seen the blood gases, they are within acceptable range. So next day morning, you have planned for decannulation of the patient. So before decannulation, 60 to 120 minutes prior to decannulation procedure, you stop heparin. You check APTT and you check ACT, they should be within new normal ranges. If cannulas were percutaneously placed, they can be removed easily and directly. You just have to apply the pressure for 20 to 30 minutes. 2 dedicated people for 2 sites of cannulation, and they are not going to do anything else in next 20 to 30 minutes. After 20 to 30 minutes of compression, you check for bleeding and hematoma formation. If there is nothing, just do a dressing and perform a lower limb venous Doppler just to see any signs of DVT. Sorry. So there is no standardized or validated criteria like ventilatory weaning, mainly because of limited data available. Now move ahead with VA ECMO weaning, slightly tricky and slightly different than VV ECMO weaning. There are multiple ways of weaning in VA ECMO. This is one method, we'll discuss it further. So once you are thinking about weaning in VA ECMO, you should achieve normal oxygenation and ventilation parameters with normal or acceptable ventilator settings with a blood flow rate of nearly 10 to 30 ml per kg per minute. That means trial of ECLS is needed. Usually it is not done in VA ECMO in first 24 hours. I prefer first 72 hours. You should not think about weaning in cardiac patients. Weaning is not continued whenever there is increasing dose of inotropes or higher dose requirement beyond tolerance levels. The weaning is usually slower with more times in between weans, and it could be as rapid as 1 hour. What parameters you are going to look for during weaning? Most important is arterial waveform. That reflects the cardiac contractile function. If there is good arterial waveform, that means your cardiac function is improving. And gradually you have to switch over to ventilatory setting which is near normal or acceptable. You have to monitor ACTs. Now if you decrease blood flows, you have higher chances of clot formation. And you need to monitor blood gases, that is pulmonary function and tissue and organ perfusion. For that you need to monitor lactates. Any rise in lactates, that means you cannot wean the patient. So weaning parameters for VV ECMO, you need to maintain oxygen saturation more than 85 to 90 during maintenance phase, and during weaning you need more than 92. For VA ECMO, you need to maintain SVO2 more than 65, and during weaning more than 70%. What are the weaning parameters when you think about weaning in VA ECMO? The most important single most parameter is increased pulsatility. There is a pulse pressure, ideally more than 30, or at least it should be more than 20. There is improvement in mean arterial pressure, more than 65 to 70 millimeters of mercury on no or very low inotropic support. You done echo, there is improvement in LV contractility, there is minimal MR. VTI you have to measure, it should be more than 10 to 12 centimeters, or tissue Doppler systolic velocity more than 6 centimeter. And for perfusion, you have seen SVO2 more than 70 if possible. So the weaning strategy, you should not think about weaning in first 72 hours in VA ECMO. You should assess for renal and hepatic function. Hepatic function improvement is important. Renal function can wait or can be delayed. Now pulmonary function you have to test. You should achieve good oxygenation and good ventilation, that too with the acceptable ventilatory settings. Hemodynamic stability must be there. Your map should be more than 60 to 65 millimeters of mercury with low or no vasoactive agents. A good pulsatile arterial waveform should be there for at least 24 hours. The patient must tolerate a full weaning trial, and on echo parameters, your left and right ventricular parameters are good, your VTI is good, your systolic velocity is good with minimum ECMO flows. So how you do it? You decrease the ECMO flow. ECMO flow is cardiac output in VA ECMO. So you decrease the ECMO flow, you decrease the cardiac output through the machine, and you make patient independent of machine. So either you do it by 20 ml per kg per minute decline, or you can just decrease the ECMO flow by one third every hour and check all these parameters again and again. And if your echo and oxygenation parameters are okay, you can move ahead with decannulation. During this weaning process, you need to monitor hemoglobin, SVO2, lactate. Lactate is usually end organ perfusion marker, heart rate, urine output, blood gases, and 2D echo monitoring. So how you do a trial of ECMO in VA ECMO? It is the last step before decannulation. If your patient successfully tolerates trial off, you can move on to decannulation. So your cardiac function slowly begins to improve. Flows requirement you are declining. Eventually you are seeing a good gases on ABG, and tissue perfusion is good on minimal ECMO support. Your 2D echo is showing good LV function and as well as good RV function. Your inotropic requirement is minimal, your ventilatory settings are acceptable level, PA pressures are under control, preferably less than 18. Prior to runoff and decannulation in VA ECMO, you should consider 2 points. One is the risk of continuing ECLS. If you continue ECLS, what are the risks you are going to handle? And second is, if you come out of ECLS, what are the level of supports patient will require if you come out of ECLS? You don't want to put again ECLS in patients. So usually duration of trial of varies between 1 to 3 hours. Like I said, you do a decline in flow by 66%, then 33%, and then stop. Yes, coming. So during trial of periods, you need to manage your anticoagulation. Simple rule for anticoagulation management is whenever your flows are less, you should give higher anticoagulation. Whenever your anticoagulation is low, you should have higher flows. That rule applies for every scenario in ECMO. So trial of, you should prepare as in VV ECMO, you should ventilate patient. This clamping method. Monitoring, simple same monitorings, what parameters we need to control are ABG, SVO2, lactates, mean arterial pressure, pulse rate, saturation, and especially 2D echo monitoring for LV size, ejection fraction, development of mitral regurgitation, and VTI. And preferentially for decannulation, you call off surgical team because there is a arterial cannula which might require surgical repair, and with proper surgical care, you decannulate the patient. Post-decannulation, a chest X-ray is mandatory. You need to check all the parameters. You treat hyperpyrexia because of the SIRS response, and arterial Doppler of the lower limb of cannulated site. Thank you.
Thank you so much, sir. Now let's delve into the combination of two modalities, that is CRRT and ECMO. To shed light on this integration, please welcome our next speaker, Dr. Ashwin Kumar Khandekar, who is a senior consultant nephrologist.
Yeah, at the outset, I must thank Dr. Rajan Barokar sir for giving me this opportunity. Now, I'm the only nephrologist probably in the crowd, and certainly not a face that you want to see when you are managing your ECMO patient. So let's see how we can, go through that situation with minimum time spent on dialysis. But sometimes we do need to combine these two things, and the occurrence of acute kidney injury in patients with ARDS who are requiring ECMO is very high, just like in any other seriously ill patient. So someone who is in ICU, someone who is on ECMO, someone who needs dialysis, there cannot be a sicker patient than this. So these are the adult numbers. 40 to 80% of the patients of ARDS who are on ECMO will require dialysis, and therefore will develop AKI, and most of them will require dialysis. So we can combine the two. The circuit is a high pressure, high flow circuit, and we can utilize that for the dialysis as well. We just need to draw a loop and do. The other thing is ECMO itself can cause acute kidney injury. There are so many hemodynamic changes. We have seen what all happens, the flows, the shears, the chatters, and it can, a lot of blood is also sucked out, so it can impact the renal blood flow. It can therefore lead to ischemia. The patient is inflamed, there is additional inflammation because of all the cannula that we are inserting. There is hemolysis going on. There might be microcirculatory dysfunction. There might be platelet and coagulation abnormalities. All this is actually adding to the renal injury. So AKI can develop just because of ECMO. And the indications, they remain pretty standard. But one of the commonest one that we are pushed to start dialysis, even when metabolic parameters might be good, is fluid overload. And somebody did mention that if you correct, Dr. Swapna mentioned that if you correct the volume well, this is the main findings of these studies, where they are saying that patients who developed fluid overload and the fluid was not able to be corrected had higher mortality. If you end up correcting the fluid to euvolumic status or even become a certain amount of negative, that actually helps better survival. So that is the crux of the whole thing. The ELSO says, and I am quoting here, return the extracellular fluid volume to normal, that is the dry weight, and maintain it there. This is so true whether it is ECMO or not ECMO, whether it is dialysis or not dialysis. Any acute kidney injury patient in the ICU, this is the mantra to go by. You have to return the extracellular fluid volume to normal. If it is low, bring it up. You'll probably prevent renal failure. If it is very high, bring it back to normal. You'll prevent a lot of fluid-related problems. In reference to ECMO and AKI, I think the ultimate goal remains to achieve euvolemia. The scope of the talk is not to understand CRRT in details, but these are the modalities that we employ. The blood is going to the dialyzer and is going back to the patient, so we want something as an access coming to the dialyzer and something as a return limb going back to the patient. So this is the scuff where there is nothing else happening. There is no dialysate flow, just some amount of ultrafiltration. If it is going continuously, we call it slow continuous ultrafiltration. Now when we remove a lot of ultrafiltration, remove a lot of fluid and replace a lot of fluid, keeping a net negative, a small amount of net negative, that becomes CVVH, continuous veno-venous hemofiltration. This adds to a lot of this adds to the convection removal, because we are removing a lot of fluid. There is a solvent drag. There are some solutes which will be taken away through this solvent drag, and then we replace so that there is hemodynamic stability. When we add dialysate on the other side of the blood flow, then it becomes CVVHD. And if we add lot of fluid removal and replacement is added to it, then that becomes continuous veno-venous hemodiafiltration. So these are some of the basic modalities that we need to know. We cannot elaborate beyond that for the purpose of time. Now, how do we deliver CRRT or any dialysis in ECMO patients? Basically, now this is something that you are used to since morning. What I want to emphasize is that there is a blood pump, and there is a limb before the blood pump, there is a limb after the blood pump, there is a oxygenator in between. Whatever is before the blood pump is negative pressure. Whatever is after the blood pump is positive pressure, high pressure. This high pressure can be utilized to drive blood towards the dialyzer or towards the dialysis machine. The negative pressure can be utilized to take back the blood back to the circuit. Now this makes you feel that there might be recirculation, but the flows are so high and the pressures are so high that the recirculation is really very minimal. And for all we know, for all we want is a filter in between. So we need not even use a machine. We can just put a hemofilter in between. This is like doing continuous arteriovenous hemodialysis. It used to be done. Now with the advent of CRRT machines and veno-venous accesses, this is no longer done. So a high pressure just drives the blood flow through the filter. There is the return again driven through the return arm back to the negative pressure. On the dialysate side, we can add either a peritoneal dialysis fluid or a simple peritoneal dialysis fluid, or the CRRT fluid can also be utilized. So this becomes like a continuous arteriovenous hemodialysis. The pressures is what we really need to understand, and the fact is that this combination, putting a dialysis loop in the ECMO circuit, is not US FDA approved. Something that we need to know. We do so many things that are not US FDA approved. But the machines, the CRRT machines, are designed to work between venous pressures of 0 to 20. And in ECMO circuit, the pressures on the negative side are much lower than this. So it is basically the pressure alarms that are going to bother you. There will be alarms. There are the newer machines can actually sense that they are connected to an ECMO circuit, and therefore not have these alarms, or the alarms are automatically readjusted. But the older machines will give you alarm, and therefore the alarms need to be readjusted, and that is the whole crux of it. If the alarm ranges are modified, then everything else can be taken care with good flows and good anticoagulation. Now this is another way, probably more commoner way, where the blood to the machine is going from the positive pressure side. It can be after the membrane or before the membrane. So this is on the positive side, and the return is on the negative side. There is some fear that the blood returning may carry some risk of air embolism, but that is very minimal, because even the dialysis machine or the dialysis circuit has air trap on the venous limb. So air embolism, the fear of air embolism is slightly exaggerated than it actually can happen. And there is a configuration which says that both the limbs can be on the before the pump also. Now this will be problematic in terms of trying to get blood at a good pressure or a good flow. So that could be one of the things. And returning could be too much, sometimes too much negative pressures that can be handled by attaching a clamp or a three-way, which can then help you slightly increase the pressures. Anticoagulation, most of our dialysis in the ICUs are heparin free. We manage them with probably some higher blood flows or flushes every few minutes. So, and plus the fact that the ECMO circuit is nicely anticoagulated, so you may not need additional anticoagulation for the purpose of dialysis. Although regional citrate anticoagulation can be employed, and CRRT machines are well equipped, and it is becoming more and more easy, because the machine itself is doing all the brain work. You just have to decide one particular goal, and the machine will adjust everything. So there is elaborate gadgetry available for managing the regional citrate anticoagulation in a CRRT machine. So that if you want to do that, that will help, because it improves filter life, it improves circuit life. Having anticoagulation also simplifies fluid management, because then there are no flushes that the nephrologist or the dialysis technician is giving. So that makes calculations a bit more easier. Troubleshooting is all about pressures. Till a few days back, in our institute, we just had one-line protocol for troubleshooting, Afzal Bhai ko bula lo. that is now changing. We have to take more of our responsibilities. If the pressures are high, then it is better that access line, if the high positive pressure in the access line, then connecting before the pump might help, but then that will become too negative. If it persists, then the last option is reducing the flow. So ultimately, as you can see, reducing the flow is coming as a last option. Before that, you have to manage pressures with either clamps or changing the access site or the return site. Complications are similar to any complications that are associated with vascular access or prolonged dialysis. It can lead to electrolyte fluctuations, it can lead to hypophosphatemia, and these two can, hypokalemia can lead to arrhythmias, there can be hemolysis, there can be, not very common, most of the problems are with hemodynamic fluctuations, fluid management, and electrolytes, especially potassium. There can be nutrient losses, and there can be hypothermia. Like I said, air embolism or air embolization, the fear is more exaggerated because the dialysis circuit itself has a good air trap and a good air alarm. So this is how it might look like. This is not from our hospital, but fairly representative. As you can see, both the limbs are certainly not coming from the patient. They're coming from somewhere in the ECMO circuit. We are not able to determine where, but it is certainly possible to set up and manage CRRT and ECMO all at the same time through a single circuit. Outcomes are poor. These are various publications, high odds ratio, in-hospital mortality ranging from 60 to 80% in ARDS with AKI with CRRT, and ranging from 40 to 80%. So as it is, AKI in ICU portends high mortality. In an ECMO patient, this is further multiplied. There are ways of predicting it. There are several scoring systems available. Not many of them include renal failure as a parameter, but this is one of the scoring systems that incorporates renal failure, not only acute kidney injury, but also chronic kidney disease. It is called the ECMO Saver scoring system, and it scores from -35 to 17. Higher the score, better is the survival. If the score is positive, more than 5, there is a good chance that the patient will survive. This is available online. You can access that. So to summarize, it is possible to combine the two. Same circuit approach is not FDA approved. Any CRRT modality can be employed. Anticoagulation can just be utilized from the ECMO. RCA does, regional citrate anticoagulation does improve the filter life. Pressure alarms need to be monitored closely or readjusted, and complications are similar to routine CRRT. Air embolism seems to be lesser than feared, and mortality is high in patients requiring both. Thank you.
Thank you so much, sir. It provided a lot of insight. Now, let's greet our next speaker, Dr. Anant Rajput, who will enlighten us on extracorporeal therapies in ICU.
So, first of all, many thanks to Kingsway and Dr. Barokar for giving me this opportunity. I'll try to do justice to the topic because the topic appears to be a little different from whatever we have been discussing throughout the day. We are talking about the other probabilities of extracorporeal therapies that probably has some future and maybe still in infant stage to discuss. Some of us must have used all these therapies at some point of time, but largely they remain experimental because of lack of evidence and objective demonstrable outcome benefit.
So topic being bigger, I'll try to skip over some slides and try to rush over some. So scope of talk includes all the common possible therapies besides ECMO and CRRT. Possible situations where we'll be looking into. So first two situations have been covered in CRRT lectures. Others are plasmapheresis, cytosol therapy, toremixin filter, MARS, that is liver replacement, and charcoal filtration. So plasmapheresis, as we had just seen in the CRRT lecture, that how we can connect. Okay, in a very similar way, if you look into this, the connections are possible for a plasma filter to be attached to ECMO circuit. What are the possible scenarios? So plasma filter is slightly different filter than dialysis filter. So we all understand what are the possible situations where plasmapheresis may be required with ECMO. So there are a huge number of indications for plasmapheresis per se. We all know that, many of us must be doing it. But primarily ECMO, if you look into, so ANCA associated conditions where there may be affection of lung or heart, and GBM diseases where like good posture syndrome and polyangiitis where both lungs are affected as well as you may require to do plasmapheresis. So for lungs, we are taking the patient on ECMO and then we are required to do plasmapheresis to treat the etiology which has caused the lung injury. Now coming to next filtration technique, that is cytosol. So what is cytosol? It's a porous polymer particle containing canister, a canister which contains these porous polymer particles, which are hydrophobic substances and they have tendency to absorb different cytokines. That was the primary intention, that it wanted to absorb cytokines. What is the difference between adsorption and absorption? Absorption is like a sponge where the water enters inside the sponge, and adsorption is the process where the particle surface is coated by whatever molecules you want to remove. Okay, so the idea here was for adsorption and to reduce the SIRS response or the cytokine, so-called cytokine storm in COVID. Okay, so we all heard cytokine storm in COVID and everybody felt that, okay, cytosol can be used for COVID. So cytosol was removing huge number of pro-inflammatory cytokines ranging from 10 kD to 60 kD particle size. Here, if you look the list, you can see staph toxin also, Clostridium toxin also, strepto. So there are some other toxins which are removed besides the endogenous cytotoxins. This is the membrane, how it looks like. And this is the spectrum of cytosol, where it works. What are the indications of cytosol? All these are indications where cytokine levels are high, right from trauma, sepsis, burns, surgery, pancreatitis, for liver support, including ARDS. So may be required for along with ECMO. So they did quite a lot of studies of cytosol with COVID, which this, and then this was published that, okay, there is a possibility, right? Because of the cytokine storm that we were hearing during COVID, but none of the trials, they could demonstrate benefit in the patient outcome. In some of the trials, I have listed some trials here. I'll not go in individual details of each trial because that is going to take time. Okay, so COVID and cytosol, the net result was the International Cytosol Registry. They demonstrated that interleukin 6 levels can be reduced from certain level to certain level with the help of cytosol. Otherwise, there is no mortality benefit, and at times, most of the studies say that there is mortality which increases with cytosol use. Okay, so associated with cytosol use, mortality has increased. So again, the situation remains dicey. So negative results of most of the cytosol studies with COVID. There are some alternatives to cytosol. So based on the same principle, there are other companies which have manufactured other filters called as Seraph 100, okay, or Oxyris membrane also, right? So these two filters, they are additionally having heparin coat inside, which also helps in adsorption of certain things. So here, when they use this, they found better results in COVID because these two membranes were not available elsewhere. So again, limited studies and limited recommendation is still there for these two membranes, but otherwise till now, I would suggest that cytosol avoiding COVID. Then comes cytosorb in cardiopulmonary bypass. So cytosorb in cardiopulmonary bypass, another theory that because extracorporeal circulation is there, so cytokine levels may be higher and can be used in different situations. So inherently, these are the conditions in which you may have more endotoxin levels or, not endotoxin levels, you may have cytokine levels which are higher initially because of this coexisting condition, and the patient is because of some reason going for cardiac surgery, right? So can we combine cytosorb there? So again, most of the situations, negative results, except one thing, that cytosorb can absorb two major drugs, that is ticagrelor and rivaroxaban. So if you are doing a PTCA to a patient and that patient lands up, or the patient is on ticagrelor infusion, or sometimes the cardiologists have given all these things, and now you require the patient to be taken on ECMO. There you want to put now, the patient needs to go for bypass, right? So what you can do is you can use cytosorb during bypass or during ECMO to remove the ticagrelor or rivaroxaban. So with that, they have found positive studies, and with that they could reduce the overall blood requirement, the length of stay, they could reduce the bleeding, overall volume of blood loss. So that benefit was there with cytosorb used in cardiac surgery. There are other indications of cytosorb. Again, as of now, what I am trying to show the list, only a few published literature is available. Rest all studies are going on for the cytosorb application. There is a cytoscore available online. You can fill up and you can find those candidates, more than 6. They are applicable for cytosorb therapy. Coming to next filter, that is toremixin filter, that is Torre filter. Here now what happens, there is a membrane. Now cytosorb had particles. Now here there is membrane which is coated with polymyxin B. And polymyxin B has properties of absorbing endotoxins. So endotoxins can be adsorbed on the polymyxin B membrane. Okay, so use of polymyxin membrane for endotoxic shock. Commonly endotoxins come from gram-negative organisms when they break down. So gram-negative sepsis, abdominal sepsis or urosepsis, most common cause of gram-negative sepsis. Now in India we have pneumonia also as a cause of gram-negative sepsis. So polymyxin B filter, that is toremixin, can be used in these situations. And the results, initially this study which was published in 2007, if you look, the results were very encouraging. The polymyxin group had very less mortality rate, recovery rate was good. Even if you look into this diagram which shows the SOFA score reduction, cardiovascular outcome, renal outcome, except the respiratory, everything was good with polymyxin B. But then the second study, which got published in 2015, which again said that there is no improvement in the organ failure and mortality benefit was not observed with toremixin. So again we are at the same point since then, and we are still trying to analyze about the polymyxin B filters which can be used to remove endotoxins. Coming to liver dialysis, that is next concept. So what is liver dialysis? Basically we are using an extracorporeal circulation to remove those toxins which get accumulated because of liver failure, right? So that is the idea. Here lipophilic albumin bound substances are also targeted to be removed. So there are 3 options that we can see. Again, we require extracorporeal circulation that needs to be established in case of liver failure. Candidate choice, we'll just talk about that in a few moments. But liver dialysis devices, there are 3 devices: MARS, that is molecular adsorption recirculating system, a single pass albumin dialysis, and Prometheus. Prometheus and MARS is almost similar, you can say, but single pass albumin dialysis means across a membrane you are passing one side dialysate with albumin. Okay, so it is just passing and getting rejected. So it's a single pass albumin dialysis, you can say. And the other places there is recirculation. I'll just try to explain. The source of MARS, just I have tried to, this is the diagram which we'll talk about. I don't have a pointer, so, okay. So patient, again blood is drawn from the patient to pump. Here there is one filter, okay, that is a high flux filter. From there, another circulation of, you can say, for the moment I will say dialysate. Okay. Another circulation of dialysate is happening, for which there is another pump which is connected to a low flux hemodialysis. So another dialysate system is circulating through this, and whatever is coming out of here is getting absorbed in the adsorbent and going back to high flux system. So this is how it is happening. So whatever toxins are there, because this circulation is rich in albumin, it is loaded with albumin 20%, 600 ml of 20% albumin. This will absorb the toxins, liver toxins across this membrane, which will be transferred to this membrane where hemodialysis will happen, and adsorption will take place here. The clean blood will be returned back to the circulation like this. Okay. So something like 2 parallel circulations are happening in Mars, right? So that is about Mars. Whereas single pass, I just tried to explain that we are discarding that albumin. We are not reusing, we are not recirculating. There is no adsorption system that we are seeing here in Mars. Here you adsorb and you put hemodialysis. That is not seen in single pass. Prometheus is similar. So what are the trials? Again, trials what suggest? They suggest that what we need to keep in mind is the reversibility of the liver disease. So eligible candidates, young candidates with acute liver failure, not chronic liver disease, should be considered for Mars therapy. So reversible causes where you can see some drug toxin or something like that, there we can consider this, but not CLD, chronic liver disease. Coming to last type of filtration, that is charcoal filtration, which contains activated charcoal. So initial studies were long time back, 1970s, 1980s, they started putting blood through the charcoal to remove toxins. Right? What was the major problem? The major issue was hemolysis. So what they did to prevent hemolysis, they coated the charcoal particle with biopolymer. Okay, so this filter came into existence, and there are several indications for this, although again same situation, mortality benefit and other things are not there, but definitely there are certain high recommendation for certain conditions, which I'll just be talking about. So this has no ultrafiltration, right? So only there is circulation happening through this filter, and toxin, whatever you want to remove, is getting removed. What are the established indications? Paraquat poisoning is the established indication. Organophosphorus may be. Carbamazepine, theophylline toxicities, theophylline, especially when the patient is having convulsion because of theophylline toxicity. You can also use for phenytoin and calcium channel blocker adsorption on the charcoal. Okay, so these are the conditions, and what is the criteria? Which patient should be, or which drug should be included in charcoal therapy? These are the 4 major points that we should keep in mind, that the drug should have low volume of distribution. It should work in the single compartment, that is plasma, okay, and minimal protein binding of that drug with low endogenous clearance. If the drug is having more endogenous clearance, there is no point in going through this charcoal therapy, right? So we discussed about the early problem, and now whatever problems are remaining with charcoal therapy, what are the problems? That is platelet depletion, fibrinogen, so coagulation disorders with calcium depletion, glucose depletion, and hormonal depletion with trace element depletion. So these are the major issues. Besides, there can be some element of hemolysis still happening with charcoal therapy. Some studies, but I will not go in much details because of lack of time. Now, what are the side effects of overall whatever extracorporeal therapies that we have seen? Hypotension, thrombocytopenia, going through extracorporeal circulation, all this, with including addition of anaphylactic shocks and cardiac arrhythmias are important thing. We should keep in mind about the venipuncture that we do for removing the blood and returning the blood. That complications of all those should be kept in mind. To conclude, extracorporeal therapies have various indications with probably lesser proven outcome benefit. Most studies are awaited for benefit evaluation. Individualize the case whenever you want to use these extracorporeal therapies. And cytosorb in COVID has failed to demonstrate benefit except adsorption of anticoagulant, that is rivaroxaban and ticagrelor. And liver dialysis, you have to be careful about the indications of liver dialysis, not in CLD, charcoal, unless the patient is planning for a bypass, liver bypass, liver transplant. Okay, so unless that is happening, we should not target liver dialysis. Charcoal filters in paraquat poisoning can be used. Rest all are not that strong recommendation, and polymyxin B filters, we are not very sure about them till now. Okay, thank you. Thank you for the opportunity, Barokar sir.
Thank you so much, sir. It was very well explained. So for our final speaker, let's welcome Dr. Rakesh back to the platform to address the clinical challenges as an ECMO physician.
So good afternoon again. So I'll be standing in front of you on the lunch. So if you interact fastly, we'll close the session fast. If you delay it, I'll delay it. Right? Challenges, yeah. Did anyone face challenges being an ECMO physician or an ECMO doctor or whatever it is? No one? Everyone is happy with the ECMOs? No. So which is the best ECMO machine in the whole world? That's my favorite question. Wherever I go, I'll ask that. Which is the best ECMO machine? Mackay, Meadows, Centrimag? Sir? The one which you are familiar with, yes. Best answer. One more answer I was expecting. Girls? Sir? Placenta. Every female is the best ECMO machine in the world. Placenta, right? Baby is the patient, placenta is the circuit, mother is the machine, right? So mother maintains the baby for 9 months. Battery is running low. So it delivers the baby. So same thing. So let us see what is meant by an ECMO physician first, and what are the challenges you are going to face it. So there are guidelines for defining an ECMO physician also. Will you accept that? Will you accept the guidelines to say that yes. So they defined it as also guidelines. Any one doctor who is taking care or who is a decision maker in the whole ICU, who can manage a patient on ECMO is an ECMO physician. They need to have a special education, training and management of the machine. So you need to understand the machine, you need to understand the physiology. At the same time, you need to understand the complications. So why it's happening only with me? Sir? Okay. So the main job of this ECMO physician is to direct the care of the patient. So ultimately, you need the outcome, right? So the one who can direct the outcome, he's the director of the movie. So anyone can become an ECMO physician. Either it might be an intensivist or a pulmonologist, cardiologist. Some centers, there are nurses and ECMO physician. Some centers, perfusionist as an ECMO physician who directs the whole thing. So there is no hard and fast rules. ECMO physician can be anyone. So everyone starts their career like this. So go touch everything, you'll get some mistakes. So once you have challenges, once you face all the challenges, you grow up to a level wherein you can debate with anyone when it comes to ECMO. So for that, you need to face the challenges. So what happened here? Coordination, lack of coordination. So if two teams are working without any coordination, ultimately you'll end up in failure. So by saying this, what is a team now? I need an intensivist. I need a primary physician to be in your ground. If you can't convince a primary physician itself, you cannot convince the family also. So there are still so many primary physicians who says no for ECMO, let us try proning, let us do all the IRVs, all ventilatory parameters and all. An ECMO nurse who is specially trained in ECMO, and a perfusionist. You need a perfusionist, you need a surgeon. One more important person lacking. He is a ward boy. So he is the one who stops all my infections. If he doesn't do his proper ward job, so everywhere it says Acinetobacter, Klebsiella, Pseudomonas, blah, blah, blah. So you need a respiratory physiotherapist also. This constitutes an ECMO team. So when you form a team, everyone has their equal roles and responsibilities. The first challenge when I say ECMO is counseling. Now, how many of you know Spike's protocol? Now, go and read it now. I'm not going to tell that. So counseling, when it comes to ECMO, you need to explain them ECMO is not a treatment. ECMO is just a support till the patient improves. The minute you say it's a treatment, they'll expect more from you. And the duration. VV ECMO is never going to be, as I said, it's never going to be a one day or a test. 2020, it's a test match. So you need to counsel the attenders from the day one that it's going to be a long run, 3 to 6 weeks of course. Complications. So you need to understand the complications. I am spending 4 lakhs or 3 lakhs summer. The whole bill comes around 40 to 50 lakhs. And then they'll expect much more expectations from you. You need to explain them in complications. Sepsis. The one who controls the sepsis is the winner here. So anyone can keep an ECMO. Anyone can transport a patient. But the thing is, no one can control the sepsis. If you control the sepsis, you are the winner here. Second thing is, one more thing is circuit life. Patients think that all of a sudden claims that you have placed a patient on ECMO, I am paying this much amount. Why the circuit is coming only for 14 days? So it's a manufacturer's warranty that says 14 days. Depends upon how good you drag the circuit. We have instances where we manage the circuit for 100 days. And at the same time, second day itself, you have to change the circuit. It depends upon how good you are managing it. Transplant. They need to understand again one more thing that comes into your mind. If the recovery does not happen, the 6th week or 4th week onwards, you should push the patient for transplant. And the huge finances, yes. Being in India, I should keep it in the first, but medical fraternity, I want to give it in the last. Huge finances are involved in the whole setup. So you need to understand, you need to make them understand that this comes with a lot of costs and outcomes. The ELSO statistics says, how much in percentage of VV ECMO patients will come out? Any idea? How are you counseling? So roughly VV ECMO, the outcomes are around 60%. When it comes to VA ECMO, depending upon the indication, the outcomes are 60 to 70. But India is never reaching that because, as I said, lack of teamwork, lack of expertise, lack of training. So team arrangements and coordination is important thing. The team leader, the ECMO physician should have the all-in-one role. He should know the role of physiotherapist, he should know the role of a perfusionist, he should know the role of a nurse and ward boy, everyone too. So be prepared for complications, the same thing which I told in the previous talk. Converting from VV to VA, bleeding, the blood bank should be kept ready, informed, sepsis, availability of blood drugs. So then we'll go into case scenarios now. So we're done with the theory part. So you have to interact now. So there is one case here, a 45-year-old male patient from Jaipur. He was shifted to our hospital. He is in refractory hypoxia. They have tried proning and all. We initiated VV ECMO. It's a femorojugular. 25 French femoral, 22 French jugular cannula, return cannula was placed. So we initiated this patient on ECMO. The minute I initiated, this complication happened. There is a hypotension, patient had a cardiac arrest. So what is the reason now? What's the reason for this? Anyone? ECMO initiation was smooth, cannulation was smooth, connection was smooth. So I said to my perfusionist to go to flows of 3 liters, 4 liters, there's a cardiac arrest happened. So what do you think, what might have went wrong? Sir? Hypovolemia, okay, anything else? Sir? No, he's on ECMO. ECMO is doing good. He's a cardiac arrest. There is no hypoxia. See, that's a sudden cardiac arrest. No, sir. No. Yes. So, anyhow, we have to do CPR. We did the CPR. Any chance? Any more guesses? So, it's a sudden cardiac arrest. Yes. So, what are the sudden cardiac arrests that happens in ICU? Yes, sir. One is embolism, an MI, tamponade. So, because we are dealing with vessels here, this patient had got a pericardial tamponade. Are we prepared enough for this now? So as I said, you need to have the Vigon or a pericardial tamponade catheter ready to tamponade, to taper it off. So before going to that, you should first treat the patient. Don't go and jump and treat the tamponade. Convert it into VA ECMO and then go back and analyze, do an echo what has happened. There is a tamponade, tap it off. Once you tamponade, patient will be out. So I need to have what things ready with me, an arterial cannula, a femoral one, Y connector. You will see the connectors in the workstations, and a distal perfusion line should be ready. So this is the patient, the same patient which has happened. So this is a femoral line and this is a jugular wherein the CPR has started. So we kept immediately converted from VV to V-AV ECMO and then went for a pericardial tamponade catheter. So wherein I connected this pericardial tamponade to pre-pump of the circuit. So it's sucking it off. So there is an RA rupture that has happened in this patient. So my jugular perfusion team, what has done, they went little bit deeper or something. What has happened, we don't know. And from this case onwards, we learned that Once the guidewire is in, you need to keep a transthoracic echo, seeing the continuous echo monitoring. Before that, I have never used a transthoracic echo for monitoring. So once I have faced this complication, went back and done a root cause analysis. Once the guidewire is in, from the minute the guidewire is in, I had to keep a 4-chamber view to make sure that whether my cannula or guidewire is causing a rupture of RA or RV. Because this patient is in severe hypoxia, his RA, RV are dilated a bit lot. So the minute the guidewire is in, it might rupture. Anything might happen. With the same with the cannulas which I am discussing prior. So the lesson learned is, no matter how many resources you have, if you don't know how to use your resources, yes, you will end up in a failure. You might have the best CT wave surgeon, you might have the best ECMO perfect, everyone will be there. But the thing is, someone should be there coordinating the things, right? We'll go to next case. A 68-year-old female patient is shifted from a private hospital to our hospital. VV ECMO is initiated outside in view of severe ARDS. This case has got diabetic, hypertensive, OSA, all complications which were there in the market. So VV ECMO initiation went on smooth. ECMO maintenance is going on normally. So this was going on smooth for us. We know it's a VV ECMO. It's going to take a long time. So it's almost 44 days of ECMO run. Still lungs are not opening enough. So now the attenders will come into picture. So it's 44 days, roughly around 45, 60 lakh, 50 lakhs of bill. So they are becoming restless and saying, why it's not improving? You are deliberately making it not to improve to pull cash from us. That's the allegation now. So what I'm supposed to do? Any answers? So then, because it's almost 44 days, I involved my transplant team. So transplant team came and had a look, saying that infections were there, obesity, critical illness, neuromyopathy by this time because of recurrent paralysis, sedations, proning and all. So they said no for transplant. So being a critical care physician who counseled on the day one, so what are you going to do now? Any ideas? What should be the plan? The patient is neither deteriorating nor improving. Patient is stuck on ECMO. With ECMO, he is very stable. He is not improving, not deteriorating. Anyone wants to take DNR? No? No? Right? So we waited, we counseled them, we took all their blunts, whatever the words they said, we said, okay, we'll wait on for some more days. Now it is day 66. Now anyone wants to take DNR? 22 days again. We counseled, we used all your counseling abilities. We bought 3 weeks of time. Day 66, still status quo. Pressure from pressure from the family. Then we did a CT scan to explain them it's going to be fibrosis. Okay. So the CT scan, obviously the radiologist said that it might be query fibrosis or a reorganizing pneumonia. He is not very sure it's fibrosis or not. He is asking me to take a biopsy sample to make sure it's fibrosis. So what are you going to do now? So again we went on, we gave the decision to the family. I said that if I am there in your steps, I'll go for DNR and or else if you want, you have the money, resources and all, we'll continue the same thing. So family was accepting now. Day 44, they're not happy with the DNR status given. Day 66, yes, okay sir, whatever you want, you get the DNR. So I removed the cannulas. So immediately patient collapsed and died. How many of you think that I did the right job? How many of you think I did a wrong job? So there comes my principles of ethics. So there's always a clash between my ethics of autonomy and non-malfeasance. So patient is actually moderately conscious. He's trying to obey for the deep sedations. And day 66, family is running out of the finances. So you need to take that call. The family is unable to take the call. They kept the decision for you. So I removed the cannulas. I don't know, there is a clash between my autonomy and non-malfeasance. So being an ECMO physician, there will be always a clash of, not an ECMO physician, any physician, there will be always a clash of ethics. When it comes to family, when it comes to you attaching together to the family for 66 days, you need to take some step forward for the sake of the family. So we did it in a good, in a good intent to do. So I thought of beneficence is dominating all my principles here. So I did all my choices for the better of the patient. Hoping so. Okay, let's move to the next scenario. Scenario 3. So it's a 34-year-old male guy, again. It's a severe ARDS, COVID positive patient. I proned him, I took all the necessary actions, but he's not improving, so went on for initiation with VV ECMO, day 5. The heparin we started maintaining the ACTs with 600 units per hour. ACT is around 180 seconds in the maintenance phase. So all of a sudden my resident comes and says, sir, he is not moving his upper limbs and lower limbs. Remaining limbs is moving. So what is the diagnosis again? IC bleed. So obvious, no, it's a quite obvious case of an IC bleed. So can you do CT scan on ECMO? Yes. Can you do MRI on ECMO? Why? Why not? It's not. So till now, there is no machine that is MRI compatible. All the pumps and the pump heads are built on magnetic levitation, or it might be magnetic coupling technology. The minute they enter into the MRI field, they will definitely stop or they become erratic. So it's only a CT scan what all you can do in any patient when you suspect an intracranial bleed. Now tell me how many how many of you wants to take a DNR? It's a case of VV ECMO, day 6, IC bleed, patient is not moving, patient is drowsy, GCS of 6. Size of the bleed, yes sir. So, yeah, there is a pontine bleed. So minimal pontine bleed is there. Yes, it's a right-sided bleed which is minimal pontine. No one wants to take DNR. Madam? Pupils are unequal, madam. Pupils were unequal. One side it is reacting though. So again the question of DNR or continuation of therapy. So we counsel the attendants regarding the complication. So how to proceed here with heparin? Anyone heard heparin-free ECMO? The first case SAR has projected is a trauma case. That was a heparin-free ECMO of 1971, right? So we are fearing that if you stop heparin, my circuit will be gone. So the first case in 1971 is a heparin-free ECMO, wherein a polytrauma patient comes to you, within 3-4 days the patient has improved. The concept of heparin-free ECMO is you stop the heparin, increase the flows in the circuit. If you increase the flows to more than 4.5 or at least 4.75 liters, the chances of thrombogenicity or the circuit loss is less. So we followed the same strategy. Attendants were not willing for DNR or comfort care. So we continued ECMO, thinking that the bleed might increase, but only thing what we did is, we did a heparin-free ECMO in the same guy. So patient has recovered luckily, but it's only from the lung wise. GCS was still stuck at E3, VT, M5. But patient was we are able to mobilize the patient. He is able to maintain on the TPs, and then we discharge the patient with a box BiPAP support, ultimately like a stroke patient. The patient's lung has improved significantly. So what helped in the improvement? 34 years. So if the guy is of around 70 or 65 years, maybe this scenario might not be there. He's a 34-year-old guy. Even I'm against DNR also for this guy. So when it comes to ECMO, the decision should be always tailor-made. You cannot have a consensus statements here. I discharge the patient with home BiPAP. So we don't know what is going to happen tomorrow, today and tomorrow. So don't lose hope. You never know what is going to come. Tomorrow might be much more better and beautiful, right? 34-year-old guy, no one wants to take a chance. Now let us see this scenario. It's a 66-year-old female. Again, multiple comorbidities were there: diabetic, hypertensive, morbidly obese, 123 kgs. Patient came with severe ARDS, COVID positive. ECMO initiated, VV ECMO. Femoral we went on with 27 because of severity and then the obesity. Jugular of 20 French. Continued ECMO for 46 days. Okay, patient was still on 46 days. No improvement in spite of proning in ECMO. So we did the track. I just kept this video just. So we'll do always on ECMO. We have faced the complication of ET bleedings. So whenever we do a percutaneous track, eventually my needle is going to damage the posterior wall. To prevent that, we will keep a bronchoscope, a bronchoscopic guide. You can see it here in this video. The minute the guide wire is in, it was towards the cephalic. Yeah, sorry. And then turn it back, yes. It came towards the camera and then turned back. So it happens in any of the patients. So after that, we dilated. You can see the blue rhino coming in. So we make sure there is no absolute posterior wall damage. The minute you damage the posterior wall, in spite of ECMO, patient dies of bleeding. That's the reason I kept this here. So in this patient, we tried proning, wherein we use the sandwich and log roll technique. Yeah. We need at least 6 guys here when it comes to proning. Sandwich the patient between 2 bed sheets, take onto your legs, and then rotate. Yeah. So we did proning for this guy, lady, sorry. So this is post proning. So someone is speaking about the space in the ICU. So see the space here. The amount of space you have to leave for 2 ECMO patients in our ICU. Both of them are prone at point of time. So you need this much of bed space if you want to establish an ECMO ICU, ECMO unit. So we did the proning. The patient has improved suddenly from 46 days, but the significant bariatric weight loss has happened. Patient recovered though, decannulated. So everyone is happy. So mobilized, yes. Plan to shift to room within a day. What complication might have happened? Any guess? Sir, DVT, pulmonary embolism. Ma'am? PE, okay. Any other thing? It's a weak complication that happened to us, sir. No? I'll just show. So before shifting, we removed the arterial line. Patient eventually after 7 hours or 8 hours down the lane, patient developed tachycardia, hypotension gradually setting in. So we thought it's a sepsis, septic flare or a. So what he said, sepsis, cultures were sent, we escalated the antibiotics. So immediately post decannulation, there will be always a biofilm around your cannulas. The minute you decannulate, let some blood goes out. So you will be obviously seeing some septic flare in any ECMO patient post decannulation, wherein we always say keep some reserve capacity for the patient so the patient improves eventually. So we thought it's sepsis. So we never, cultures were sent to escalate the antibiotics. Now patient herself started saying that, sir, there is a pain, please observe me what's happening to my catheter site. So this is the first time I'm seeing catheter site pain and swelling. The minute went and opened the bed sheet, there is a huge thigh hematoma. Patient was in a hemorrhagic shock, and the minute we saw it like, acha, we blunderly missed some complication here. We involved our vascular surgery team. They shifted the patient to OT, but after 8 hours, started on CRRT. She went into severe hemorrhagic shock, no use. Patient was declared dead. In spite of our 47 days, 48 days of hard work with a percutaneous track, under bronch, proning, all our hard work went in a 1 day. Just matter of seconds, because either me or I'll take the responsibility. Either me or my boss, or no one has observed the patient, just removing the blanket. So we're just treating the symptoms or just treating the number, tachycardia, fever, sepsis, kya ho raha hai, but that's the thought process. We never took one step forward and the minute when the patient said there is a pain. So this is the left groin hematoma that happened to the patient. So we learn from the mistakes, right? I just wanted to project this because you should not do the same mistake again. See this hematoma. The minute we kept some needle, it's a femoral artery pseudoaneurysm that happened after the removal of our monitoring. You keep the arterial line for monitoring, right? So the pseudoaneurysm got ruptured. And slowly the hematoma changed. By the time we realized this is the situation. So VA ECMOs, no more adventures. If you want to remove an arterial cannula, I'm talking of ECMO cannula, involve a CTVS surgeon. If you are removing a peripheral arterial line, even in your normal ICU patients also, don't allow your respiratory therapist or a physiotherapist to do that. Better you do it by yourself, so that a simple mistake, it costed a life. Luckily, we escaped because of our counseling. Family is okay, but they eventually accepted the fact. So again, the question. The take-home point is, every step is important. Don't celebrate too early. Always remember the tortoise and the rabbit story. So the minute you said the cannulation is done, yes, celebrate. Don't be like that. Till the patient gets discharged to home, make sure the patient is properly taken care. As ma'am and Sas are saying, there one more patient where post-decannulation, he is already on heparin since long time. We thought patient is getting mobilized, no need of DVT prophylaxis, because patient is mobilized and walking. He developed a PTE. We can save the patient though. What happens, there will be a rebound thrombogenicity in a patient who is on heparin. The minute you stop, that's the reason why we club heparin with warfarin in pregnant patients when you want to shift or do a surgery. That's the reason why. To prevent that rebound thrombogenicity, you will add one more drug in spite of heparin. That's the reason behind. The same thing, every step is important in ECMO. Don't get, carried away by the success. Okay. And don't let the success go into your head. Case 5. So it's done, sir. Last case. Nothing much to show. 45 male. It's in the first wave of COVID, severe ARDS. Since first wave, I think it's in April or May. Severe ARDS, despite proning, unable to maintain the saturations, we went on there, call for a peripheral VV ECMO. It's an off-station ECMO initiation. Initiation went on smooth. We plan to shift to KIMS for further management. So we had a checklist before initiation. We had a checklist for transport, planning for support, planning for shifting. So everything went on good. So during the transport, we faced a lot of problems. So I'll just show the problems what we faced. The ambulance space. Till now in India, there is no particularly defined ECMO ambulance. If you can see the space, my perfusist is holding the machine on his lap. Luckily, it's a Centrimag. He can hold that 5 kgs or 6 kgs. If it's going to be a Mackay and an old Madas machine, he cannot hold it off. And hardly it fits 3 people. I cannot do anything inside the ambulance. I cannot give fluids. I cannot do, just monitor and see what will happen. Otherwise, if it's a complication, I have to stop the ambulance on roadside. Then I realized that ambulance space is very congested. Is one more thing. And another thing is the power supply. The ambulance power supply is very less, wherein your ECMO machine consumes 220 volts of power supply. The same thing with the flight also. See this flight, anyone is finding any difficulty? Or it looks very good? I should have taken a video, but at that time I don't have an idea that. So this is a structure, and you can see the entrance of the flight, no? So for a person to come out itself, he has to bend and come out. But I have to shift this whole patient inside the flight like this. So every inch, you have to move it separately. So it became very tough for us to shift the patient inside the craft. And the guy who is holding this oxygen pipe from the tarmac ambulance to the aircraft, that's almost 5 meters of length. We don't have the oxygen pipe length of 5 meters. So while transporting, keep some extra circuits or pipe lengths. So in between, we realized that we are shortage of this pipe. Somehow we made a jugaad. We shifted the cylinder also with that, shifted the patient inside. And this is the aircraft space. The same space as the road ambulance. Even aircraft is much more congested. The minute it goes up, I have to take the permission of the flight captain. Sir, can I stand? Sir, can I move to that side? Because if I move somewhere, it's going to fobble. So the captain said that for saving one life, you will risk 5 of our lives. Don't do anything once the patient is in air. You just monitor the things. Anything which I am going to do, I have to tell him. Myself of 80 kgs, if I move to that end of the flight, it might fobble again. That's the reason. Power cords, oxygen cylinders. So you need to calculate the amount of oxygen you have per minute. If the flow of oxygen is 6 liters per minute, calculate the flight distance, ambulance, shifting, everything together. If it is 4 hours, 4 into 60, 240, 240 into 60, around 14 liters of oxygen is required, plus extra 5 liters. So you need to have that thing in your mind. So for 20 liters of oxygen, how much cylinders I need to have? So power cords is one more thing, because R has shown previously, in the loss of power, you have to do the hand crank till the whole flight, right? So this is the situation inside the flight. This is one more flight. So I had to kneel down. I had to do something for the patient from the head end. If something happens, I have to kneel down. You cannot stand also. So this flight is a luxury flight which we got from Delhi to Hyderabad, wherein they have removed almost 20 seats of the passengers in the front, and they're given a space for us. Yes, if you are fine like this, it's a luxury, but they charged. I don't want to say the numbers yet, no. So once we reach it off, again deboarding is important. So only lesson learned is try to take some bodybuilders along with you when you're planning for a transport. So the minute I landed in Hyderabad, it's like total body pains. I cannot lift and see. I cannot concentrate on the shifting. So many things running in my mind. That's my first flight transfer. So that's a lesson learned here. So take home points, you should be always prepared for any complication. You cannot say, I didn't expect this. This should have taken prior. Please don't say all those things. Patience. So ECMO needs patience, as I said, especially VV ECMO. Counseling ability. If you're not a good counselor, please step aside and let a new counselor or the new one who's good in counseling ability in your team, let him counsel the attenders. Skill, so obviously it will come. So all-in-one roles. I cannot say this is a perfusionist job. Say for example, there is a sudden decannulation happened. Perfusionist has to come and clamp it. No, you should be knowing that where to clamp, how to clamp, to ban it. To do the emergency span. So suddenly if there is a leak that's happening at the hematoma site, no, my surgeon has to come and repair. Come on, keep your finger there. So it happened for me for a same, if I remember correctly, no? So we thought in the initial VA ECMO decannulation, first 2 VA ECMOs decannulation went on fine. Apply a suture, keep a pressure, madam. It settled off very well. Third ECMO, it's not at all settling down. It's like a gush coming from the femoral artery. I had to keep my little finger inside and wait for the surgeon to come. So after the surgeon came, he took the sutures around my finger and then he, in a snap of a second, he did it. Then he gave me a look. "Tu kya re, idiot, why are you doing all these unnecessary things?" So then, no, what is adventurous things, especially when you're dealing with artery. Call the surgeon, take the help, don't go for egos. Transport, prepare for anything when it comes to transport. You need to have so much of checklist and all the things. Foresee the upcoming complications. That's the biggest ability. Thank you so much.
Thank you, sir, for such an engaging, fun, and enlightening presentation. So it was a tremendous honor and delight to have you all for this educational celebration. Without further ado, I invite each individual to step forward as I call out your name to receive your token of appreciation. Your commitment and efforts have truly made a difference. Allow us to welcome the first recipient of our token of appreciation from Dr. Professor Manimala Rao ma'am as we kick off this ceremony of honor and celebration.
Dr. Anand Singh Rajput. Prabhat Datta, sir. Dr. Prabhat Datta. Dr. Munish Chauhan. Sanjeev Bes. Dr. Rakesh. Arranged Sanjeev Bes. Dr. Rakesh. Rakesh, Dr. Rakesh, sir. Dr. Ashwini Kumar Khandekar, sir, after that. Dr. Afzal Sheikh. Pooja Wadwa. Ramesh Hasani. Dr. Sagar Chopde. Sandeep Gajme. Stavan Seja. Dr. Vijay Lanje. Santosh Manak. Dr. Rajan Barokar, sir, himself. Dr. Virendra Belekar. Rashmi Agrawal, ma'am. Thank you.
So, friends, we have completed our lectures, which were marathon lectures. I know it is a bird's eye view for a ECMO workshop. Now we want you to actually explore the ECMO skills, the nitty-gritty of ECMO at the ECMO station. So they are 30 minutes each. We'll be rotating you in 6 batches. The division of each batch has already been done. If there is any doubt, we'll announce that again. And before that, you please, we invite you for the lunch, a quick lunch, a light lunch, not the heavy one, so that you can enjoy the workstations. Thank you so much.
The batches has been divided from A to E. It has been mentioned on your batch. So you can join the respective sessions, left corner. So the A batch goes to first station and they will move on accordingly. A, B, C, D, E, F.